Great. Hi guys, hope you are doing great. So let's get started for today's session. Great. So give me a quick thumbs up with respect to the audio and the visual part, and we can get started for today. This is the first test of this test and explanation series. So welcome to the entire discussion. I can say at the moment it is not about how much you know, but how do you apply it. I mean, obviously everybody reads the notes, but then it is all about application in the entire pressure cooker situation, as I like to call it. Now, pathology is the backbone of medicine, and in fact it's not only the backbone of medicine, but in fact of all the 19 subjects, so all subjects would in some way relate to it. And there are three core things that I would like to emphasize in today's discussion. One, I would like you to solve the MCQs in a similar kind of a fashion like you would do in a written exam. So I would like you to be all sitting up and not lounging and comfortably lying in the bed. Try to solve the questions in a manner like you would try to show that same kind of aggression like you would show for the actual exam. Second is what I'll do is I'll teach you how to eliminate the various options. That is of paramount importance. And the third thing is integration of the key points. So during this discussion, I'll be telling you various clinical stems which are important. We'll discuss the various possibilities whenever they give you a question on any kind of a lymphadenopathy, which is happening to be one of the initial questions. So the main objective of this discussion is to try and correlate the entire information of pathology with the clinical domain as well. Once I've spoken about these 3 points, then I want to bring to your attention that smart strategy and hard work will ultimately result in development of results. And we have a 30-60 rule which I have seen students are able to apply very effectively. Try to read a question in 30 seconds and try to answer within 60 seconds. And believe me, if any question is taking more than 90 seconds, it is a bouncer. You need to let it go. So मेरे हिसाब से it is one of the most important thing is कि 90 सेकंड से ज़्यादा का जो टाइम है अगर किसी क्वेश्चन पे लग रहा होता है तो that means कि वो नहीं हो पाता है. तो there is no point of ruminating over a question for a very long time. That is what I see students doing, and lots of time they change answers also. So with these few words and tips which you are intelligent smart boys and girls who can understand, let's start with the first question for today. And let's evaluate your responses as well. So it's on a war footing. Let's get started. Yes, Komal, Prashant, Saurabh, Vivek, Raghu, Rahman, Ketaki, Shreya. So everybody, I think we are good to go. Fine. So we have this 20-year-old man. He's come with 6 weeks of painless enlargement of the cervical lymph nodes. There is a rubbery consistency present. And then he has given those category B symptoms like fever and weight loss and loss of appetite, which is so common for the Indian subcontinent, and both with respect to tuberculosis as well as for malignancies. Now he says which of the following is correct about it. So I want you to hit the comment button very soon with respect to what is the finding that would be seen here. And I'm getting comments there also. Okay, Shruti came up with D, then there's a C. So obviously there's going to be a mixed bag. So let me just zoom into this image. There are 2 clinical pointers in this question. The first clinical pointer is that there is mention of rubbery consistency of lymph nodes. In TB, we have is a matted consistency of lymph nodes क्योंकि उसमें lymph node आपस में चिपक जाते हैं. लेकिन यहाँ पे discrete lymph nodes होते हैं और discrete के साथ में they have a rubber ball consistency. Now, when you zoom into the diagram at about 11 o'clock, you can notice that very classical Reed-Sternberg cell that I've currently marked before you. In fact, if I go even at 9 o'clock position, instead of, I'll use a different marker. I think yellow will be more contrasting there. So, if you look at this 11 o'clock position and then even at this 9 o'clock position, you can see that classical Reed-Sternberg cell with that classical owl-eye appearance that is present. And like I said, that even if you're not able to pick up the Reed-Sternberg cells, the clinical information itself was very, very characteristic in this question. That is that the rubbery consistency of lymph nodes was given. So therefore, the correct answer for the first question that we're discussing today is for a 20-year-old guy, there was a rubbery consistency of lymph nodes. We are also able to demonstrate the presence of Reed-Sternberg cells. So the correct answer in this case would be Hodgkin's lymphoma. I agree to the fact that Indian subcontinent, one of the important causes for cervical lymphadenopathy is TB. So I will be showing you the image of caseating granulomas also subsequently, but like lots of time, like cervical lymphadenitis may not be tuberculosis and could be a possibility of a malignancy as well. Then you get a stellate granuloma and cat scratch disease, and sarcoidosis has non-caseating granuloma. So what you will do in this particular case is that we will be doing a quick practice with respect to Hodgkin's lymphoma. So Hodgkin's lymphoma में Hodgkin's के mnemonic से फटाफट से पढ़ लेते हैं. One we have is a histological hallmark of Reed-Sternberg cells, which are commonly seen in the Indian variety that is called as the mixed cellularity. Then आपने देखा होगा Hodgkin's lymphoma बहुत lean discipline में चलता है. What I mean by lane discipline is that the lymph nodes will be having a contiguous spread. What I mean by orderly spread is contiguous spread. Like first the horizontal chain of lymph nodes would be involved, then the vertical chain of lymph nodes would be involved. When one side is involved, then it's going to spread to the contralateral side. So this is going to follow the lane discipline. Like, normally in India, people always break the rules and they keep on switching between the lanes. But like in West, where like people tend to follow rules a little more, like Hodgkin's lymphoma will be spreading that or would be spreading via contiguous spread lane discipline. Then there is a dual age peak. D se ho gaya dual age peak. Most of the time the cases would be seen between 15 to 35 years of age, and then the second peak is seen after 55 years of age. So यहाँ पे एक parallel example बोलना चाहता हूँ. जैसे मेडिसिन में आप जानते हो कि valvular aortic stenosis is either seen very common in pediatric age group or is seen in geriatric age group, bimodal age of distribution. Similarly here, Hodgkin's lymphoma also shows a bimodal age of distribution. Then there are various group types which are present, like nodular sclerosis, which is the common one. The Indian variety happens to be mixed cellularity. And I would like you to comment in the chat box, what is the most common variety of non-Hodgkin's lymphoma? We're discussing Hodgkin's also. So in the chat box, please comment what is the most common variety of non-Hodgkin's lymphoma. The key trigger in this case is going to be Epstein-Barr virus. Sometimes the clinical manifestation can be given pain in the lymph nodes after drinking alcohol. That's a very peculiarity. There is no explanation given for that in the books, but yeah, the books do say that there is rubbery consistency of lymph nodes, and at the same time there would be intolerance to alcohol as well. And the question that I put up was, hit the comment button guys, hit the comment button. Very good. As far as the most common variety of non-Hodgkin's lymphoma is concerned, it would be diffuse large B-cell lymphoma. And then one of the fundamental differences between Hodgkin's and non-Hodgkin's is Hodgkin's will mainly be developing in the lymph nodes, nodal disease, whereas non-Hodgkin's can be extranodal also. So also comment in the chat box, what is one of the commonest sites of extranodal involvement in non-Hodgkin's lymphoma? Yes guys, options if I give, then it will become much more easier. So do let me know. The most common variety of non-Hodgkin's is diffuse large B-cell lymphoma. That is okay. But then we had an extranodal involvement as well. So yes, very good. I think the comments came very fast. The extranodal involvement that would be seen would be with respect to stomach. Like I can remind you of a tumor by the name of maltoma that is caused by H. pylori that would be developing in the stomach of the patient. So we'll talk more about non-Hodgkin's lymphoma at the moment, but Hodgkin is a quick mnemonic that helps you remember the manifestations with a histopathology slide showing presence of Reed-Sternberg cells. Now over and above this, what I also want to bring to your notice from the clinical STEM perspective is कि TB में जो lymph nodes होते हैं ना, they tend to वो आपस में चिपक जाते हैं. They tend to have a matted consistency. They'll stick to each other. So if you get a question in an Indian patient with matted consistency of lymph nodes with fever and weight loss, then obviously you will think in terms of tubercular cervical lymphadenitis. That is one of the commonest forms of extrapulmonary TB. Yes guys, the most common form of extrapulmonary TB is not tubercular meningitis, it's not Addison disease, it's not Pott spine, which will be given in the options. The most common I would say pulmonary manifestation with respect to tuberculosis would be tubercular cervical lymphadenitis. But when it comes to rubbery consistency of lymph nodes, it's a lymphoma that I'll be suspecting, and obviously what I would like to do is go ahead with a excision lymph node biopsy so that I can differentiate between the two, and you guys can comment quickly regarding the third clinical STEM related to this question, that is mediastinal lymph nodes in a young female with hypercalcemia. Quick answers guys. No, I'm not serious guys. Not serious. ओके PDF मिलेगा डॉक्टर साहब बट अभी तो लेट्स ट्राई टू फोकस ऑन द कोर एस्पेक्ट्स. चलो ओके कूल. फटाफट से आंसर्स करो भाई. Mediastal lymphadenopathy in a young female with hypercalcemia would be sarcoidosis, क्योंकि जो नॉन केजेटिंग ग्रेनुलोमास होते हैं वो यहाँ पे विटामिन डी बनाते हैं. You know, the non-caseating granulomas will be having an enzyme by the name of 1-alpha hydroxylase, and that 1-alpha hydroxylase will be causing that synthesis of vitamin D3. So you also get a question on steroid responsive hypercalcemia. Then the next clinical stem that could be asked to you is again with respect to cervical lymphadenopathy, but the questions in the previous years have been like a bit of overlap from surgery, that is left supraclavicular lymphadenopathy in a 65-year-old man. Here there is like abdominal metastasis, abdominal tumor that will be exhibiting mets by the thoracic duct. This is what we call as Troiser sign. Yes guys, quick comments in the chat box. In Troiser sign, what is the common cancer that would be involved? So the bottom line is, whenever we are talking about Troiser sign, that is a left supraclavicular lymphadenopathy, the cancer is going to be spreading from the stomach via the thoracic duct, and that's going to contribute to this left supraclavicular lymphadenopathy. Yes, GI cancer, GI malignancy is a very good answer. It can be stomach cancer, it can be pancreatic cancer, colon cancer. So it is like GI malignancies contribute to Troiser sign in a patient. And let's have a input with respect to the last one. Yes, very good. Gastric adenocarcinoma, pancreatic adenocarcinoma, those are some of the common answers that you would be giving. Yes guys, shorty lymph nodes in a child. Shorty would mean like lead shots. They're like super hard lymph nodes which are present. Shorty lymph nodes. If I was talking about shorty lymph nodes in a sex worker, you know, it could be a male sex worker in a female sex worker, then I could have thought in terms of a STD also, that is secondary syphilis, jahan pe where the lymph nodes are going to be very hard in consistency, like lead shots. You know, when I was saying rubber ball can be squeezed and lead shot cannot be squeezed. So I said three things: matted, they are stuck to each other. Then is shorty, like lead shots, or there's going to be like rubbery consistency where they can be squeezed gently. Yes, secondary syphilis is perfectly fine for a sex worker, but in children you might be getting discrete lymph nodes in the neck sometimes, which could be common after any viral infection. So the message is shorty lymph nodes in a child. If it is asked, then obviously I will not answer it as a case of syphilis for obvious reasons. Then it would be answered as a viral infection. So these are like couple of questions, like I would say those one-liners or those clinical stems which would help you. And since one of the options was sarcoidosis, so I think all of you would have read rapid revision. You would have listened to ma'am teaching you about this classical image, which I think is a favorite with all pathologists, that non-caseating granulomas that are present. And in these non-caseating granulomas, you will also be having is, as I zoom into here, presence of asteroid bodies. So whenever you read about sarcoidosis, you read about Schaumann bodies and asteroid bodies, as you can see in the image at the moment. So the bottom line is, like sarcoidosis, the manifestations would be Schaumann bodies and skin lesions. Can you comment in the chat box, what is the skin lesions that are found on the shin of a patient of sarcoidosis? Yes guys, waiting for your answers here. What is the skin manifestation that would be seen in a case of sarcoidosis? There are Schaumann bodies, there would be skin lesions that would be present. Yes guys. This would be lupus pernio, right? Very good. That is lupus pernio. That would be purple lesions that are present. So for sarcoidosis, I want you to remember minimum for S for sarcoidosis is asteroid bodies and ACE levels elevation, because lungs are getting involved. Then R would be restrictive lung disease that can be seen in these patients that will cause pulmonary fibrosis. There can be hilar lymphadenopathy also. You see, hilar lymphadenopathy causes obstructive lung disease. So spirometry cannot be used to differentiate whether person is having sarcoidosis or not, because obstructive pattern bhi milta hai and restrictive pattern can also be seen. That is why we need to do a CT guided biopsy. I mean, if he says what is the investigational choice, it would be a CT guided biopsy that would help us in diagnosis sarcoidosis, because spirometry and routine function test or lung function test would not give us any information. Then another clinical information that I've already said is sarcoidosis would be having 1-alpha hydroxylase enzyme. In your and my body, 1-alpha hydroxylase is present in the kidney. But in this patient, there would be like 1-alpha-hydroxylase in the kidney. Instead of kidney, like even in the granulomas, that will cause more synthesis of vitamin D3 and calcium levels will increase in a patient. And then C would also be responsible for the fact that caseation would be absent. And for those who are asking for like guarantees, we don't give any guarantees here, guys. So like, we just try to focus on the hardcore information. And then is the ocular manifestation, that is panuveitis, which is present here. So what we are trying to do here is discuss the remaining options of the question as well, because we are not focusing on like A, B, C, D is the answer to a question, but we try to rule out the remaining options also, because if there is a presentation of lymphadenopathy, then sarcoidosis would not be far behind. Let's just finish this question by lastly mentioning regarding caseating granulomas. So all of you are aware of the fact that caseating granulomas will be having presence of Langerhans type of giant cells that you can see in the image. And not only do you get caseating granulomas in tuberculosis, but they can be seen in fungal infections also. That would be histoplasmosis, blastomycosis, 2 C's then, coccidomycosis and cryptococcosis, which contribute to even meningitis. And then you have a Rose-Gardner's disease. Quickly comment in the chat box, what is Rose-Gardner's disease, guys? Yes, guys, Rose-Gardner's disease would be sporotrichosis. So if like the image in this particular question that I have currently given to you was the way I have currently described with that pink material in between, the Langerhans type of giant cell that is present, the cheese-like caseation that is present, that then we'll think in terms of like a tuberculosis as one of the possibility for this particular case. And the last one, as you can see, is cat scratch disease. So hit the comment button, everybody. You have to do 2 things simultaneously. In cat scratch disease, where there is a stellate granuloma, please tell me the organism and tell me the treatment as well. I'll give you 10 seconds to think about it. What is the organism that would be responsible for contributing to cat scratch disease? Yeah, Bartonella Hensley. Also comment here regarding what is the treatment that would be given. And please no chat GPTs to be used here. That's a boon nowadays, right? You just click a picture of the question, put it there, and it gives you an answer immediately. I mean, we never had facilities like those in earlier times. So cat scratch diseases, Bartonella Hensley, very good, very good. I think most people have answered correctly. Minor lesions of cat scratch disease can be like self-resolving also, but if the lesions are multiple, like the cat scratched a person multiple times, then there is bound to be like treatment that needs to be given. Yes, so one of the treatments that we can give is doxycycline. The first treatment that is usually given is azithromycin. So we usually, like if it's a small lesion, it may resolve on its own, the immunity part, but otherwise azithromycin can be given, or even doxycycline might be required in some patients, but in immunocompetent patients, I'm writing about immunocompetent patients, like person like you and me, healthy person playing with a cat, in immunocompetent patients, it is azithromycin that would be used in the patient. So the correct answer for the first question that we have discussed is presentation of Reed-Sternberg cells of Hodgkin's lymphoma, and we move on to the second question for today. We have a 2-year-old child who's having recurrent pneumonia episodes. A lot of questions in the paper begin by recurrent pneumonia episodes. And then there is a mention of delayed dentition, which is present in this case. And he says that the patient is also having elevated levels of immunoglobulin E levels and eosinophils to be present. Well, somebody just commented randomly for that silicosis, the common infection that we see is tuberculosis. But at the moment we're talking about a child, no. So no occupational disease here. Yes, very good. Because immunoglobulin E levels are elevated in this condition, that is why the answer in this question would be given as Job syndrome. Job syndrome, the main aspect is that the Th17 cells are not functioning well. So therefore the neutrophils here are of poor quality, and because of count may be normal, but quality is bad. And because of poor quality, that is why recurrent pneumonia episodes can be explained in these patients. But at the same time, Th2 cells activity in these patients is rather increased, and Th2 cells then produce interleukin 4, interleukin 5, and that causes eosinophils in these patients to be increased. Now, why is the answer not Shedek-Higashi syndrome is because most of the time in Shedek-Higashi, though I have discussed it even in the later part of the question series, usually they would be mention of oculocutaneous albinism, which could be coexisting in a patient. Along with this, they can be peripheral neuropathy also. Because of peripheral neuropathy, the question will also talk about ataxia. So Shedek-Higashi will also begin with recurrent infections only. But what are the additional things that you need to look in the question? Oculocutaneous albinism and ataxia. A very close answer in this question is Dye-George syndrome. I think everybody knows. Please comment in the chat box. Which chromosome defect is responsible for Dye-George syndrome, guys? It's a defect of the third and the fourth brachial pouch, no? The third and the fourth brachial pouch. So the chromosome that would be involved here in this case is, yes guys, quick comments here. Which chromosome would be involved? Yes, it is Cas22. That is chromosome 22 that would be involved. Very good, Rashmi. Very good, Aparna. I think the people in the app are doing excellent. And in this condition, then we get couple of manifestations, like you can be getting cardiac involvement present. You know, most of the time the question on Dye-George syndrome could be not only talking about infections, but even co-truncal abnormalities or co-truncal cardiac defects can be present in this patient. Along with this co-truncal defects, because here parathyroid gland nahi banta, because parathyroid gland will not be developing properly, so there can be hypocalcemia that can explain the development of delayed dentition even in this case. So if you read this question carefully, in the first line, recurrent pneumonia episodes and delayed dentition, the answer could have been Dye-George also. But Dye-George syndrome will not be having increased levels of immunoglobulin E and eosinophilia. So that is like the key word for this question, that IgE levels and eosinophilia part is the key word for this question. We will be having hypocalcemia with thymic hypoplasia. And because of this thymic hypoplasia, as you can understand, if T cells are not there, there is bound to be infections occurring in a patient. So most of the time, the questions that are present in this patient will be describing manifestations of hypocalcemia. That could be delayed dentition, short stature, or rickets-like presentation in a patient. Ranjan, you said a seizure. It's a little unlikely to have hypocalcemia so severe that there would be tetany and then there is a laryngospasm and then there is a seizure. I mean, thoda sa, you know, it's gonna be a little far-fetched. So I think like we'll go by the standard dictum, that is a rickets-like illness. And in chronic granulomatous disease, the problem in the patient would be a failure of respiratory burst. I will talk more about like chronic granulomatous disease in the later part, where we get infections from catalyst positive organisms. We have tests also available like dihydrorhodamine test, which is a flow cytometry based test for diagnosis of this condition. But because of the failure of the respiratory burst, yes, even there recurrent infections can be present. So the learning point is all the four options begin by describing recurrent infections, but then we have to look for a differentiator. The correct answer in this case is Job syndrome, and the mnemonic to remember Job syndrome is ABCDE stat. For a good job, you know, you need to learn basics, and if you learn basics, then you get a good job. So what you get from A component here is autosomal dominant and abscess formation, and then there is poor quality neutrophils. So because of poor quality neutrophils, there would be bronchopneumonia occurring in a patient. What is the problem with the neutrophils? The problem in the neutrophils is chemotaxis of the neutrophils is defective. Like once I was saying respiratory burst is defective, here I'm not saying respiratory burst. I'm saying it's the chemotaxis of the neutrophils. For, you know, the neutrophils are gonna hit the bad guys, you know, like we had a war across the border, so we hit the air bases, so we have to send in our jets. Similarly here we need to send the security team. So chemotaxis of neutrophils is like the good guys, the security system going in, that is gonna be defective in this particular case. We get coarse facies, we get delayed dentition as was mentioned in the MCQ, and then comes the E component, that is increased immunoglobulin E levels in this patient. So one basic TCO, everything falls into place. So ABCDE stat. Now what do you mean by the word stat? The word stat here is for the mutation that is seen in this condition. What is the mutation present here? STAT3 mutation. There is a STAT3 mutation which is present here. And what does the STAT3 mutation causes? What I said in the beginning, Th17 cells are not going to function properly, and Th2 cells will be having a dominance, and you are all aware that Th2 cells would be causing more production of interleukin 4, interleukin 5, which cause an increased eosinophil production in the bone marrow of the patient. So there are two things that are happening which are the cause of this problem. One, Th17 defect causes neutrophils to be ghatiya quality, poor quality, and the Th2 dominance stimulates the bone marrow to contribute to more production of eosinophils. So that would be like the correct description for the question. So very well done guys. I think you did a great job by solving the second question, and let's move on to the third one for today. He says, which of the following cells is responsible for producing circulating antibodies in response to an antigen? Super easy question here. So hit the comment button, guys. Okay, I'm getting answers here. B, great. Naive B cell, activated B cell. Okay, great, great. Let's wait for a few more seconds, and I expect more comments. I mean, come on, man. You are so many in the chat. You need to just flood the comment box with the chat with the answers. Okay, great. Guys, B lymphocytes are responsible for antigen detection. They are not responsible for antibody production. B lymphocytes, guys, what is the function of these? They are basically responsible for antigen detection. They are not responsible for antibody production. Antibodies are produced by plasma cells. You first have a naive B cell, then you have an activated B cell, then you have plasma cell, and this plasma cell is the one which is responsible for that humoral immunity. So the correct answer for this particular question is option number C. Yes, guys, be very, very clear. Some of the questions will be testing your basics. Like question number 2 was like in-depth knowledge. Like somebody has to read STAT3 mutation and then understand why do you get eosinophilia in a job syndrome. Like I provided the reasons before you. But for this particular question, this can be solved by even your knowledge of biology. I mean, this does not require some special cells or special, neuronal activation to be done. So it's going to be mixed bag. It's going to be a roller coaster ride in the actual exam. And that what happens is some questions we do overthinking and some questions we do underthinking. So if you got it correct, cool. In case you got it wrong, then it was simply a fact that we were being casual about it कि यार ये तो आता ही होगा और ये तो मैं कर ही लूँगा, and this is not gonna be a difficult one. But then sometimes the examiners are like smart enough to induce some errors. Okay, moving to the next one. We have this 12-year-old boy with rheumatic fever and he's receiving benzathine penicillin prophylaxis. Now you're aware in rheumatic fever, we give benzathine penicillin, long-acting penicillin injection to prevent recurrent sore throats. And then a horrible thing is happening that should never happen in career of any doctor. There's urticaria, swelling, histamine being released, so hypotension because of vasodilation and bronchospasm causing breathing difficulty. The patient has developed a type 1 hypersensitivity reaction, that is anaphylaxis. This is anaphylactic shock, and the bad news is anaphylactic shock will cause extensive deterioration of the patient because there would be histamine liberation that is occurring here. Hit the comment button, guys. I'm getting predominant answer as option number C for this, that is immunoglobulin E mediated complement activation. Guys, immunoglobulin E to theek hai, but there is no complement activation that is occurring here. There is no complement activation occurring here. There is no destruction as such happening. No, it is bronchospasm. It is laryngeal edema that is occurring. It is swelling that is occurring. So the correct answer for this question is obviously not C. This is again a replication of what they're doing in the FMGE exam. Like I'm talking to a lot of students who are saying कि sir मेरे number तो 170 बन रहे थे recall में, but in actually I got 149 or 148 or 147 because lots of time we assume that this is an answer to a question which is not the case. So you have to read the information properly. First and foremost, I think all of you have, I think ma'am has told this upteenth number of times that immunoglobulin E antibody is an extravascular antibody. It is the only antibody that does not cause complement activation. Right? Immunoglobulin E antibody is the only antibody that does not cause complement activation. Complement activation किससे होता है बच्चे? Complement activation is by immunoglobulin G, immunoglobulin M, that is classical. It is caused by immunoglobulin A, the alternate pathway, but not immunoglobulin E. Immunoglobulin E तो complement activation करती ही नहीं है. Immune complex deposition तो SLE में मिलता है. So 2 options have been ruled out. Now you have to select between A versus B. Hit the comment button again, guys, and let me know what do you think is now the correct answer to this question. And the surprising thing is I've discussed it in my medicine part also, but today is hardcore pathology, so you have to be very, very clear about it. Yes, guys. Very good, very good. Now the answers are coming. Anaphylaxis में जो cell involved होता है, anaphylaxis में जो cell involved होता है, it is not eosinophil. Anaphylaxis is the baap of allergy. Anaphylaxis is like that super allergy that is happening. I'm not talking about routine allergy. I'm not talking about atopic dermatitis, asthma, hay fever, stuff like that, right? I'm talking about something very serious that can jeopardize the career of a doctor because patient may die. It is basophil mediated, guys. Anaphylaxis पढ़ो आज आप अपने notes को फिर से पढ़ो. If you got this question correct, cool. If not, you need to read your notes again because 3 and 4 constitute silly mistakes, and silly mistakes are the ones which pull down the score. So we need to minimize those silly mistakes that we tend to occur. It is basophil mediated interleukin 4 release. It is basophil related interleukin-4 release that is responsible for anaphylactic shock in a patient. So the correct answer to this question is option number B. And at this point, I also want to warn you, in paper, sometimes question number 1 might be so easy that you might say, "Mujhe sab aata hai." And sometimes it can be so difficult that you are wondering what is going on. So don't get every MCQ's result decided the next MCQ's result. You have to be neutral for 2.5 hours. It's all about, nobody can read everything, but one has to learn to apply. This is an application of whatever that I'm telling you. The correct answer for this question that would be given is option number B. So yeah, interleukin-4 release, no? And then subsequently there would be like bronchospasm, laryngeal edema that is occurring in a patient. And yes, anaphylaxis does not contribute to laryngospasm. It causes laryngeal edema. That is why cyanosis will occur, and we have to give intramuscular adrenaline for this patient. Now, I'll not get into the treatment of that today because we have separate days for that when we'll talk about the treatment part. But for today, the pathogenesis of anaphylaxis, as I said, is it is like the BAP of allergy, right? That super aggressive allergic reaction that is occurring that might cause a patient his life, and that is why it's a basophil mediated interleukin-4 release. So we are sorted for this question number 4, guys, and do check out your notes once again. Okay, coming to the next one, histopathological findings seen in a liver biopsy of a diabetic patient. Diabetes is so common in India. 12%, 11 to 12% of India is all diabetic here. So let's focus on the current question, guys. HbA1c of 12% means that guy would be requiring insulin management, and he says like, what is the histopathological finding that would be seen in this patient? Yes, in the chat I'm getting a lot of good answers. I'm getting a C, Kimmelstein-Wilson change. Now read the question carefully. Is he asking about kidney biopsy or is he asking about liver biopsy? Are you imagining answers for today? Ain't you imagining answers like, you know, इसका आंसर यही होता है. Yes, guys. Kimmelstein-Wilson change, Armani-Epstein change are two changes that are seen in the kidney. The question is on the liver biopsy finding, man. Kimmelstein-Wilson change would be involving the glomerulus of the patient. And Armani-Epstein change would be involving the tubules of the patient. I agree Kimmelstein-Wilson change is a nodular glomerulosclerosis. I agree to that, Nikhil Bache. I agree to that. But read the question again. What is the histopathological finding in liver biopsy of a diabetic patient with HbA1c of 12%? You have to solve this by simple exclusion. In diabetes mellitus, there would be deranged lipid profile. Triglycerides become more. When triglycerides will become more, they will contribute to development of steatosis. They will contribute to fat deposition in the liver. There would be a development of non-alcoholic fatty liver disease. And the finding that we get in non-alcoholic fatty liver disease would be Mallory-Highline bodies. Guys, every time you are having a non-alcoholic fatty liver disease, though there is a new term for that also that I'll be describing. When it comes to, yes, very good. Nikhil, you did a great job. Perfectly fine. You are doing a great job at the moment. So, yeah, Councilman bodies are seen. I'll show you the image of Councilman bodies also, bache. Councilman bodies are seen with hepatitis C or even with hepatitis B sometimes, but like Mallory-Highline bodies are a feature of non-alcoholic fatty liver disease. Rishabh says Mallory-Highline is only seen with primary biliary cirrhosis. So I will break that myth. So what is the mnemonic that you need to upgrade for Mallory-Highline? Mallory-Highline bodies are one, eosinophilic inclusions inside the hepatocytes. What you can see is this would be an hepatocyte. There is this eosinophilic inclusion that is present inside. Councilman bodies are apoptotic hepatocytes. They are like, I'll show you the image of that also. But these are pink structures like this, which are present inside a hepatocyte that you can see at the moment. Now the mnemonic for this is, I will break alcohol status. That's the mnemonic to be remembered. If you have ever been to an Indian village, people cannot afford melanin or stainless steel utensils. They tend to use copper utensils, pital ke bartan. So because if an Indian mother will be boiling milk of a child in a copper utensil, it will contribute to Wilson disease-like manifestation in a child, in a sense that copper toxicity will be seen. This condition, which is exclusive to the Indian subcontinent and is becoming lesser because now people are economically better, but because of use of copper utensils, you get this Mallory-Highland bodies or Denk bodies in Indian childhood cirrhosis. In I will break alcohol status mnemonic, W will be standing for Wilson disease, where you can be getting it. Then in primary biliary cholangitis, in the late stages of PBC, that is primary biliary cholangitis, would you be getting it? You also get it in patients of alcoholic hepatitis, and you also get it in patients of non-alcoholic fatty liver disease. And non-alcoholic fatty liver disease term is not used anymore. Nowadays, the term that is used is metabolic dysfunction associated steatotic. It is MASLD. It is metabolic dysfunction associated steatotic liver disease, MASLD, as a term that is used nowadays. So one, you need to be aware of the new terminology, that is non-alcoholic fatty liver disease, and second is that these are the conditions in which the Mallory-Highland bodies can be seen in a patient. Rishabh, you mean that primary hepatic cause diabetes? No, doc, it's the other way around. Like diabetes is causing the liver damage. So I get your point, like what you're trying to say, bache. But what I'm trying to say is that diabetes has caused fatty liver in a patient. That is a standard presentation. All diabetics have fatty liver, and this fatty liver can contribute to even liver cirrhosis in these patients, which is the reason why in India nowadays, like the requirement of liver transplantation and kidney transplantation is increasing in a patient. So these are like manifestations where we get Mallory-Denk bodies, and the correct answer for this question is option number A. And like all of you were right if this question was on the topic of a kidney biopsy. Like if I was saying diabetic nephropathy, then cool man, and never an issue. I mean, your answer of Kimmelstein-Wilson would have been perfecto. But at this moment, it is like Mallory-Highland bodies because it's the liver damage that has occurred in a patient. So we sorted for this question. Let's move to the next one. We have this 50-year-old man. Here I can take easy, right? He is presented to the OPD with heartburn and cough and a 25 history of smoking 2 packs daily. College जब से जा रहे हैं तब से cigarette पी रहे हैं. Now he says, which of the following transformations would be commonly seen in the lungs of this patient? I think a very simple and easy question. Okay, let's see the comments. Okay, so it's between A versus B only. See, the question is talking about lungs, right? It's not talking about esophagus. The question is not on the topic of Barrett's esophagus, though heartburn is a symptom that is present in this patient, but heartburn can occur in any normal person also due to stress, due to drinking too much of dark coffee, eating too much of chocolate. Heartburn can occur in anybody, and smoking also decreases the tone of the lower esophageal sphincter. He's saying what transformation will be occurring in the lungs of the patient. In the lungs, we have his pseudo-stratified ciliated columnar epithelium. So columnar will get converted into squamous. The correct answer for this question is option number A. Guys, हमारे lungs में, in our lungs, what is the epithelium? Is it squamous epithelium or is it a columnar epithelium? It's a columnar epithelium, no? Your answer of this squamous to intestinal columnar epithelium is valid for Barrett's esophagus. What I have tried to do here is, and especially if you are giving this exam for the second or the third time, if you are a repeater, you will understand the exact way the examiner is trying to twist our mind. So I've tried to replicate the same thing. He'll introduce a word and we tend to focus on the word heartburn. But the presentation that he's saying is not for heartburn. It is like cigarette smoking, which is contributing to transformation in the lungs of the patient. So, bache, what I want to tell you is that you need to focus on language of the question. Why I'm conducting this session in English is also one of the reasons here that I want to say that when we discuss in Hindi, people are very happy. But paper, is it in Hindi? Paper is in English, right? It's hardcore British English. In paper, it is hardcore British English. It is the language. I mean, when I speak to students, they say, sir, when I attempted the paper, it was like more like I'm being tested for English rather than my medical knowledge, right? The ifs and the buts and everything. So what I'll do is that in majority, obviously because I'm mother tongue, some words will come out by itself. So please excuse me for that. I mean, you know, when you are speaking your mother tongue, then some words will come out. But like majority of the discussion that we'll be having over these next couple of months will be English focused. The primary reason for that is that paper is in hardcore English. And it's the interpretations of the terminologies which is important. The correct answer for this patient, no doctor, it's perfectly fine. You don't need to apologize. What I want to say is don't rush into answers. I gave you the 30-60 rule. Read a question. What you're doing is you are answering within 30 seconds. You have to answer after 30. आप करके देखो, try to do that. Once you hit that beyond 30-second mark and go up to 60, that is when your strike rates will automatically improve. When we jump into an answer, there is bound to be some trick in a question. We'll try to forget it. So these are gonna be like couple of yes, exam mein, yeah, exactly, Ranjan. I agree to you. That's one of the common things that we are saying. Yeah, Tanushri, we are doing for NEET PG also. Currently, I am doing the FMG part, and then later on the NEET PG part would also come in, but you can participate in the next question. Hemosiderin-laden intra-alveolar macrophages. Even in your NEET PG, there was a question on heart failure cells now. So I'm giving those heart failure cells to, check out those hemosiderin-laden brownish cells which are present in the lungs of the patient. So he's saying like which of the following conditions would be responsible for contributing to this manifestation. Well, I solved the question by just saying the word heart failure cells, because the moment I say the word heart failure and the moment I say left ventricle failure, the only option that will fit in here will be dilated cardiomyopathy. Dilated cardiomyopathy will contribute to biventricular failure, but that means there would be left ventricle failure. And left ventricle failure will then contribute to development of pulmonary edema. And because of the pulmonary edema, along with the fluid, some RBCs can also leak. If there is increased hydrostatic pressure in the lungs, then some fluid will leak. And along with the fluid leaking, there would be some RBCs that would also be leaking, and these RBCs will get disintegrated. So the iron, which is going to be liberated from the destruction of these red blood cells, will now produce hemosiderin, or will get converted into hemosiderin, and therefore hemosiderin-laden macrophages would be present in this particular case. The question was very simple, right? It is heart failure cells, but the word heart failure word was not given. It was like hemosiderin-laden intra-alveolar macrophages. That means that along with fluid, some RBCs are also coming, and those RBCs will break down, and that is why hemosiderin would be produced. The correct answer for this question is option number C. Option number A is a dummy choice. Hemochromatosis causes bronze diabetes. Hemochromatosis damages the skin, so we get as bronze diabetes in a patient. Damage to the skin, bronzing of the skin, pancreas gets affected. Liver cirrhosis will be getting in a patient. Hemochromatosis due to recurrent RBCs, doctor will mainly be responsible for like bronze, the triad of bronze diabetes that I'm mentioning before, that is going to be, what are the main organs that are involved? It is the liver, it is the pancreas, and it is the skin that is involved in usual cases of hemochromatosis. That is one. And if you look at cor pulmonale in a smoker, cor pulmonale causes right ventricle failure. But for development of heart failure cells, you need which ventricle failure? Left ventricle failure. Cor pulmonale causes right ventricular failure. It occurs due to cigarette smoking. The right ventricle will fail, but it does not cause pulmonary edema. Na? The highlight of this particular cell is that there has to be a pulmonary edema present. And construction worker in a cement plant, that's going to be like asbestosis and silicosis. So even those would be discussed today. But the correct answer for this question is option number C. I hope it is very clear, guys, that if I had said the word heart failure cells, the strike rate of this question would have been much more than what actually I saw. But what the examiner will do is he'll give you a description of the cell. We all, I know madam has told it beautifully, heart failure cells seen in left ventricle failure, pulmonary edema. So if that is the language, excellent scores. Now what they do in the paper is change the language there. So, no, this test is not more tricky than the real exam. If you listen to the recall surgery, सुनना कभी मैंने 200 in the PrepLadder channel I have discussed 280 MCQs, and believe me, the FMG questions, they made me scratch my head more than the NEET PG one. NEET PG I was able to put almost 198 questions I was able to put them within one day, and in FMG paper it took me almost 3 days to put up all the questions. One was obviously the issue with the recall, and second was the language of the questions. It was crazy, man. Just check out those 280 questions, or check out a reel that I put up 1 to 50. Just listen to that And then talk to those people who were unlucky, right? They're obviously going to be lucky souls who will sail through and get. I have toppers also, sir. They get 250 marks. I'm not talking about them. I have people who got 253. I'm not talking about that guy. 253 guy does not need me. He does not need anything. He does not need an app. He does not need PrepLadder. He does not need anything. He's a brilliant guy. He'll clear it by himself. I'm talking about average hardworking people who managed to get 151, 152 after sheer dedication, but there are a couple of unlucky souls who are like 148, 149. So my message to you is don't lose hope. And like for those who are first attempters, I want to say that first attempt is the best attempt. Be all out aggressive. Don't wait for ki abhi to time hai, right? That time will never come back. So be super aggressive in your approach and you would be like, be able to pull it off. And yeah, I mean, if you're proud of your scores, great. If not, then it's okay. Fine. Let's move on to the next one. This is application. Patient came with pitting pedal edema. The LFT is okay, but serum albumin is only 2 and the KFT is deranged. So that's where the kidney problem is starting from. The KFT, the patient is deranged with massive proteinuria. HbA1c is 10%. So I know that he's talking about nephrotic syndrome because he's written the word massive proteinuria. You see, for nephrotic syndrome, a triad should be satisfied, no? The triad of nephrotic syndrome is 1, there should be edema. Second, there should be presence of massive proteinuria. And the third component of nephrotic syndrome that we are able to see is hypoalbuminemia. So the triad of nephrotic syndrome in this question is getting satisfied. Why it is happening is because of diabetes mellitus, because HbA1c of this particular patient is 10%. So what is happening in this patient is a development of secondary nephrotic syndrome. Diabetes mellitus causes diabetic nephropathy and causes a secondary nephrotic syndrome, which is why this presentation is coming. And then he says which finding is more likely to be seen in hematoxylin and eosin presentation. Now, I have seen a lot of comments which are coming in. One of the very good comments that is coming is nodular glomerulosclerosis. Please check out your notes and tell me that what has ma'am told for nodular glomerulosclerosis, that is Kimmerstin-Wilson change. Is it better seen with hematoxylin eosin stain or do you need special stain for it? Because nodular is going to be a characteristic feature where mesangium is involved. Mesangium is inside the glomerulus. So it is more difficult to see with hematoxylin and eosin. I agree to what you are trying to say that, sir, characteristic manifestation of diabetic nephropathy is nodular glomerulosclerosis. I buy your point. But what are the special stains that are required? The special stains to see nodular glomerulosclerosis are like trichome stain, or it is a PAS stain, or it is a silver stain. And hematoxylin, here he's saying hematoxylin and eosin staining. Hematoxylin and eosin staining is going to be like, specifically for diffuse glomerulosclerosis. The correct answer for this is option number A, guys. This is secondary nephrotic syndrome. This is not a case of amyloidosis, bache. I got even D in the options. I got even C in the options. C and D are features of nephrotic syndrome which is caused by amyloidosis. Is this question caused by amyloidosis? No, it is caused by diabetes causing secondary nephrotic syndrome. So you have to select between A versus B, and B is picked up by trichome, PAS and silver stain. So it is gonna be A. And the commonest comment that I gave after the paper is paper was very easy, sir, but it was very tricky. And I'm getting the same comments at the moment also. So what we are trying to do is, this tells me that we're doing the right thing. If you check out any comments after the paper, it was very easy paper, sir. But it was tricky because if it was easy, then we would not had a 19.8% result, right? We would have had a 50, 60, 70, 80% result. So paper is always easy. Questions always look easy, but they're always tricky. Okay. Sir, you saw, no, 19.8% or something like 20% only. No, if paper was easy, everybody said, sir, paper was super easy, but then it was not like that. And same happened with INI-CET also. Okay, moving to the next one. Which of the following is going to be not correct about T lymphocytes? Easy question, T lymphocytes. Very good, very good. Hit the comment button, guys. T lymphocytes are for type 4 hypersensitivity. That I know, that is okay. They constitute a large amount of peripheral blood cells. We need killer cells. No, we need more killer cells than the B cells. So that makes also sense. No, we need to kill the bad guys. So they have to be like tough guys in the bloodstream. So makes sense. Between A versus D, T lymphocytes, where are they produced? They are produced in the bone marrow and they get matured in the thymus. Guys, please listen to this carefully. A lot of people are reading from biology or are reading the notes casually, and they think that T lymphocytes are produced in thymus. T lymphocytes are not produced in the thymus, they are still derived in the bone marrow, but they get matured in the thymus of the patient. They get matured in the thymus, lekin bante, manufacturing occurs in the bone marrow only. The basic point is they are present in the paracortical areas, whereas B lymphocytes are present in the germinal centers. The correct answer for this question is option number D. Very good, Saurabh. You said the very right thing. They mature in the thymus. So option A is correct. And this is a table which is given in your notes. Whether you check out your rapid revision notes, whether you're going to check out your main notes, the difference between T cells and B cells is given both in microbiology as well as in pathology. The question is just derived from there. They are produced in the bone marrow, but the maturation occurs in the thymus. We need killers in the bloodstream because there's going to be bad guys. And the location of this is paracortical. So if you just analyze this table, then you are able to figure out the answer for this question. The correct answer for this question is option number D. And yeah, you will get a PDF, guys. You'll get it via mail also. Subsequently, you can annotate it subsequently. You can write down by this yourself. And then if you practice these questions with a downloaded version of this video once again, I want you to attempt this test second time also. I want you to upgrade your marks. I mean, whatever you obtained today by doing the test, that is excellent. But I want you to get even better marks and mix out and minimize your silly mistakes also. Okay जी. जो B cells होते हैं ना बच्चे, they are present in the germinal centers. That is the center wala part, the B cells, no? B looks like a bulb, no? Bulb going deep inside. So that is in the germinal, like B alphabet when you write, no? The B thing, this goes little deep inside. So that is in the germinal centers there. Okay. Next is liver biopsy of a patient. He's having jaundice and elevated liver enzymes for previous 6 months. Talks about chronic hepatitis in an IV drug user, and the guy is hepatitis B positive. Like IgM antibody is not there, but IgG is there. So this chap is having chronic hepatitis B. And he says, what is the finding that is seen in this patient? The very classical finding of hepatitis B is the ground glass appearance. Very good. Now the strike rates are suddenly going up, right? So because you picking up the words very correctly, this is hepatitis B that we're talking about. This patient is an IV drug user. No, he's not diagnosed with hepatitis C, man. Right? Yeah, you can do retest subsequently also. That's never an issue. It's a chronic hepatitis, or you can just scroll through the solved paper only, no? And you can analyze it. Like I can see if this, I think it will be too boring to give the same test again, no? So once you attempted it, you can see the attempts that you've done. But then revising whatever you've done at the end of the day would give you like you see. It's not a subject that is weak. It is the subtopics that are weak. So you need to upgrade those subtopics there. Yes, that is C for the core antigen here. So it's chronic hepatitis B. Ground glass appearance would be present. The next question is again from FMG exam. This was a HRCT finding that was given. And you have to select between asbestosis and silicosis. Ground glass appearance on a HRCT with fibrosis of the interalveolar septa. Because of the combination of the two findings, we will also call out a crazy payment pattern. So I can expect the comment button to start going crazy with the comments. Is it asbestosis or is it silicosis? Ground glass appearance, a miscellaneous question before we go on to next one. Ground glass appearance on a HRCT with fibrosis of the interalveolar septa causing a crazy payment pattern would be seen with which of the following? Yes, very good. Silicosis. It is silicosis. But if I remove the word, if I remove this particular word, fibrosis of the interalveolar septa, and I just say ground glass appearance, then it is seen with asbestosis. So there have been two different questions in two different times in your paper in which he has mentioned simply ground glass appearance on chest x-ray. That would be asbestosis. And second time he has mentioned ground glass appearance with fibrosis of the interalveolar septa causing a crazy payment pattern. Then the answer is silicosis. So that's an important aspect to be remembered. The next aspect to be remembered here is the physical appearance in the slides. If you look at this slide, I'll use a yellow color. You can see this densely, I'll use a thicker yellow. You can see this densely eosinophilic cell which is present here. This is what is technically taught to you as a Councilman body. So the first slide that you can see is a apoptotic hepatocyte. That is a Councilman body. It is going to be pink in color. It's like a hepatocyte where the nuclear condensation is going on. But in the second image, which I've shown already also, you can notice that there is a pink thing present inside the cells. This pink thing is Mallory-Denk bodies that you can see. They are intracytoplasmic. So the message is, if they give you a slide, then if the pink thing is inside the cells, you are thinking in terms of Mallory-Denk. If it is going to be outside, like in the area that I marked here, extra, I would say hepatocyte, then it is Councilman body. And the third finding that you can see here is this peculiar appearance of the cytoplasm. The cell is like the site. Okay, I'll zoom in. Like you can see the ground glass appearance of the hepatocytes here once I've zoomed in into the slide at the moment. So 3 histopathological slides have been shown here. That is Councilman body, then is Mallory-Denk, and then is the ground glass appearance of the hepatocytes. That is a feature that is seen with hepatitis B. Additional point, ground glass appearance on X-ray can be seen with vape. I mean, people do use those electronic cigarettes and vaping nowadays and harm their lungs. But for doctors, the vape is viral pneumonia, fungal pneumonia. Viral would be like COVID-19, fungal will be pneumocystis jirovecii. A is asbestosis, then is going to be early ARDS, good Pasteur syndrome, premature lungs. Premature lungs is hyaline membrane disease, and extrinsic allergic alveolitis, that is hypersensitivity pneumonitis. So yep, this is ground glass appearance on a chest X-ray. Stating this once again, guys, a ground glass appearance of ground glass appearance on a chest X-ray with fibrosis of the interalveolar septa is silicosis. But if it is a plain chest X-ray given ground glass appearance, then you have to answer it as what I just said at the moment, that is asbestosis. Okay. Councilman bodies, doc, would be more for patients where they are progressing towards cirrhosis. You know, chronic hepatitis B, when they progress more towards later part of chronic persistent hepatitis, and then they progress into cirrhosis. Before conversion into cirrhosis, the chronic persistent hepatitis is where they would be like Councilman bodies. But at this moment, like it's a chronic active hepatitis 6 months into the disease. So what I expect is that they would be like the ground glass appearance of hepatocytes. The surface antigen is full in the patient. So Ankur, you have a good point, but then we have to select the most appropriate option here. Cool. Moving to the next one, we have this 35-year-old female. This is a repeat from last time's FMG exam only. The question has been modified only in the options. Theory stem is same as the last time's paper. Progressive limb weakness and muscle wasting for past 1 year. So it cannot be Guillain-Barré syndrome. I mean, anytime you get a question on leg weakness, you have to think in terms of GBS, but here like there is no limb weakness that is described. There is no limb weakness in short duration. It is for 1 year. There are features of lower motor neuron lesion, fasciculations. There are features of upper motor neuron lesion like hypertonia. And he has himself said amyotrophic lateral sclerosis is present. So what is the bodies that would be present here? I think everybody hit the comment button correctly. That would be Bonina bodies. Lewy bodies is what we'll be seeing with Parkinson disease. Hirano bodies would be the Taujica disease, that is Hirano bodies for Alzheimer. And Lafora bodies, quick comments here. Lafora bodies would be seen with patients of, yes, very good. Bonina is the correct answer. Lafora bodies for no chat GPT. Yes, guys. Lafora bodies for, yes. Dr. Kaur, you can direct that query to the, team, right? Not to me. The test would be available, doc. Yes, Lafora bodies would be seen in epilepsy patients, guys. It is not LD bodies. It is epileptic patients who are having complex epilepsies where we can have Lafora bodies present. So I think like Pick's disease would be having Pick's bodies, no? Pick's disease is pink bodies, that would be frontotemporal dementia, and Kala-Azar would be having LD bodies, that are Leishmania Donovan antibodies. So the correct answer for this one is C, that is an easy one, Bonina bodies for a disease having lower motor and upper motor neuron lesion. Doc, will use this channel for like the academic discussion only. If you have any issues, like, you know, just message the support team. They are bound to send you across the help support. Okay. All of the following changes would be seen in reversible cell injury except. Pretty straightforward ones because I put in couple of twisted questions in between. So I'm giving you easy ones, some breathing space, which will always be happening. The most important thing is whenever there is going to be presentation of, okay. Okay, so whenever there is going to be like apoptosis occurring in a patient, there is bound to be nuclear condensation. And that nuclear condensation is what we read is with respect to pink-nosis. So the correct answer in this case would be option number B. I think most guys have given that very, very correctly and very beautifully there. And like there are a lot of mnemonics for this reversible and irreversible cell injury. For the irreversible cell injury, we'll be having like the most characteristic thing that would be happening is these terminologies, right? Pink-nosis, karyorrhexis, and karyolysis. Pink-nosis would basically mean that there would be a nuclear chromatin condensation. I can put this on this slide only. The chromatin condensation part. And after the chromatin condensation part, the next thing after this in pyknosis would be karyorrhexis. When I talk about karyorrhexis, what will happen is that there would be fragmentation. Rhexis basically means that the nucleus will begin to break, that is fragmentation. And then is the karyolysis component in which there would be dissolution of the nucleus of the cell only. So those are like the very characteristic manifestations that you see. Pyknosis, that is the chromatin condensation, then is the fragmentation and the dissolution that would be occurring. And the remaining findings are like, very well studied by you from the mnemonic perspective also. So I think this is one of the first things that they teach you in pathology, reversible and irreversible cell injury. In reversible, there is going to be like, the cell swelling, the hydropic changes that can be occurring, loss of microvilli, and light nuclear changes and chromatic clumping can be present, but not the word chromatin condensation. If I say the word chromatin condensation, that would go in favor of irreversible injury occurring in a patient. And it depends on cells to cell, which cells would be having highest chances of suffering from damage, then it is neurons. And in contrast, fibroblast would be having like very great chances of survival even in the setting of hypoxia. But brain dies within 4 minutes. Cardiac tissues die within 20 minutes. Like somebody has a heart attack, then cardiac muscles will die within 20 minutes. Brain cells will die within 4 minutes in case of a cessation of circulation in a patient. The correct answer to this question is option number B. Easy one. I think 11 and 12 are like super easy. Moving to the next one, ghost cells. Booth wale cells. The ghost cells are ones which would be having outline of the cell will be maintained, but the nuclear and the cytoplasmic details will be lost. You're doing great, man, but I think the way the questions are designed, somebody commented on a score. I think you should be getting something in excess of 50 marks. So just check out like whatever is the downfall. That would be my suggestion to you, doc. I missed your name, sorry, but that chat went up very fast. Okay, ghost cells would be found in. I think that can be easy because I said the boundary of the cell is present, but the cytoplasm is gone, the nucleus is gone. So this is a fact-based question that would be seen with respect to patients of burns. I mean, the tissues are going to be totally affected significantly. That would be, with necrosis, this kind of manifestation would be present. That is coagulative necrosis is where this kind of a manifestation would be occurring. So you read about this whenever you read about the necrosis component and when you read with respect to the coagulative necrosis component. Great. Then is which of the following is not a pro-apoptotic regulator? A similar question was asked in this time's FMGE exam also. So I have just modulated my options. Doc, don't worry. Like you might have got 30, you might have got 29, but you are at least trying to know na yaar ki if you say that okay, my pathology is easy or the paper is easy, then like we should avoid silly mistakes. I think all of you who have attempted the paper, you could have easily got 15 marks more. Minimum I'm saying, minimum I'm saying that 15 marks more could have been obtained simply by giving more time to the MCQs. Whatever marks you have obtained today, whether you've given, whether it's 30, whether it's 45, whatever, 38, whatever, you easily can score plus 10. Without reading any extra notes, I'm saying. Without reading extra notes, I'm saying. Just by doing a bit of application. So this is why we are doing this match practice, no? This is just to let you know that with practice, everything becomes perfect. That is the bottom line. When you practice every day, when you go through the grind every single day, then it becomes a habit. Like, when do you eat? When do you eat? You get hungry. So similarly, when do you study? Not when you feel like, right? It is like that fuel to the brain. The fuel to the brain is obviously glucose, but the fuel has to be knowledge also, because knowledge is power. And with that, why would somebody pay you, right? Somebody is going to pay you that money only for your brain capacity. So, as simple as that. So, okay, let's move on to the next question. Which of the following is not a pro-apoptotic regulator? So, BARC, then BAX and P53, they are basically going to promote apoptosis. But we have a list here. MCL wale, no, that is block cell loss. BCL stands for block cell loss. MCL can be used to remember that modulate cell loss. So the point is, if you block the cell loss, if you modulate the cell loss, then they would be anti-apoptotic factors which are present. So pretty straightforward one. BCL, BCL-XL and MCL1, that is modulate cell loss, are like the kind of terminologies that you need to remember are gonna be anti-apoptotic, whereas the initial ones which are given on the top would be pro-apoptotic. So more of that, I would say, fact-based questions, and you did a great job for them. Let's handle another one like this. Which of the following is correct regarding superoxide dismutase? Superoxide dismutase is an important enzyme with respect to two disorders, amyotrophic lateral sclerosis and Menkes disease. That's a miscellaneous fact that I put in while I wait for your answers. Dr. Aisha, my only suggestion would be that you try to focus on whichever are your weak links, and you would be able to pull through. Yes. English, superoxide dismutase. Superoxide radical is the one that would be degenerated. Two options are off the cards right away. And it is superoxide to be converted. And what is superoxide converted to? It is converted to hydrogen peroxide. The question is screaming out loud, get me correct, get me correct. It is like that I don't need knowledge of too much of knowledge. I don't need very too much of clinical information to solve this kind of a question. I could rule out two options, and then is like what is generated? Hydrogen peroxide, and that's the function of superoxide dismutase. And if the activity is less, then there can be neurodegenerative disorder like amyotrophic lateral sclerosis, which Stephen Hawking was suffering from. You know, all a great scientist who spoke about the concept of a black hole, and on whose novel that movie Gravity, if you watch the movie Gravity, that movie Gravity was made on, that is like Stephen Hawking. Okay, great. Let's move on to the 16th one, though I've already given you a heads up with respect to this. 6-month-old male is having sparse kinky hair. That's one of the key word in the question that you always pick up. Kinky hair, developmental delay, and a low serum copper. So we are talking about Menkes disease. Menkes disease is X-linked recessive. This would always be a boy, and he'll be having mental retardation, kinky hair, and the defect that is present here is ATP7A. ATP7B are defects which are related to Wilson disease. So I can rule out option number C and option number D right away. It is ATP7A defect with a decreased activity of the copper zinc related superoxide dismutase activity. The correct answer in this question is option number B. Everybody knows ATP7A for Menkes, that's okay, but then the question's options were a little extended by the examiner here. He also talked about the SOD activity, which is lesser, so the free radical injury would be much more pronounced, and that would explain that kinky hair, and then the low copper levels would also be affecting the functioning of various enzymes in the body, so the survival part in this kid would be substantially low. Okay, the answer to this is option number B. Let's move about a para or a transcellular movement of phagocytes. You see, the phagocytes have to go and they have to kill the bad guys. So the process is what is called as diapedesis. Now the question is a not based question on the process of diapedesis. Like he says, what is not going to be happening? So you need integrins here, because the cells have to go and bind first to the cells and then subsequently migrate in a transcellular fashion. So PCAM is the one which is involved here, the cell addition molecule, which is also referred as CD31. It occurs in post-capillary venules, and in lungs it happens in the capillaries. So three statements are fact-based questions or fact-based statements for this, but it is not a bi-directional movement. It is a unidirectional movement, and only one thing will happen. Either the security system will die or the bad guys will die. But it's not that the cell is going to come back into the blood vessel. So the word that has to be picked up here is simple English, bidirectional movement of white blood cells. It's not bidirectional. I mean, the security system cell is not going to be able to come back into the blood vessel once again. The correct answer for this is option number D. What we're talking about here is diapedesis. That is like the initial step, the transcellular movement, and this would be followed by chemotaxis, where like the subsequent part and the ingestion of the bacteria would be happening. Okay. Another question on recurrent infections. Another question on, Dr. Satya Chaudhary, you're right, the unidirectional movement would be occurring. Now, another question on recurrent infections. This is time skin infections without pus formation. Pus is dead neutrophils. Dead neutrophils. here, like the neutrophils security system is not working again. The key word in this question is the statement of mine. Okay, if I say anything more, the answer will become obvious. I almost blurted out the answer. Delayed umbilical cord separation is the main pickup point in this case, where there are recurrent infections that are present. And that will immediately rule out a couple of defects here. Like Shedek Higashi, I have already told you that there will be a question mentioning oculocutaneous albinism, nothing given here, or peripheral neuropathy explaining ataxia. NADPH oxidase is chronic granulomatous disease, where we read about infection with catalase positive organisms, and there is a problem with respiratory burst. But at the same time, you do not read about delayed umbilical cord separation in this condition. So I've ruled out two options before you. Either it is going to be a case of severe combined immunodeficiency, or it's going to be a case of leukocyte addition defect, which I almost blurted out as an answer. The correct answer for this question is option number A. It is a deficiency of CD18. It is a LAD defect, guys. It is LAD. It is a leukocyte addition defect that is happening. Now at this point of time, my suggestion to you is, like, if you got this correct, cool. If you had any issues in solving this question, then immunity part of yours is weak. I repeat my statement, it is not subjects that are weak, it is subtopics in the subjects that are weak. Like if I talk about medicine, people tend to do GI okay, hemat okay, they're bad in cardio, they're bad in neuro. Similarly in pathology, I've seen people to be good in systemic pathology but bad in immunity component. So I have a table here in front of you where I have compiled all the routine immunity based disorders with respect to what is the problem in this patient, and what is happening in this case is autosomal recessive disorder, that is leukocyte addition defect is present, which is related to CD18. So there is a impaired neutrophil addition and a migration. The most important thing in this question would be late cord separation, LAD, leukocyte addition defect. So how to remember that? It is late cord separation. Normally you read about umbilical stump bleeding, but I'm telling you today late cord separation and a immunity related defect present in this. So LAD is leukocyte addition defect, and there is a late LAT, L say leukocyte, L say late cord separation present here. So therefore the correct answer for this question is yes, option number A that I've currently explained. And adenosine deaminase would be like severe combined immunodeficiency, where again, like none of the remaining options in the question would be having this classical association that I mentioned of delayed umbilical cord separation. And the problem in this condition is again poor quality neutrophils. No, neutrophil count is like high, but they're not able to stick, they're not able to do their job properly. That's why I said like the quality issue is present in this case. Yes, you are picking it up perfectly. I have to cover the whole thing. So Shedek Higashi is coming up. Though how will Shedek Higashi be given to you? They may not give you this image of neutrophils which is having the dirty cytoplasm where there's a defective phagocytomal activity. So I agree that if they give you the image, then this question is a piece of cake. But even if they don't give you, then you have to pick up recurrent infections is anyway there. But look at that, no? Silver gray hair and light colored eyes, that is oculocutaneous albinism coming in, no? And then he's mentioned ataxia also, that is the peripheral neuropathy which is present in this case. The silvery gray hair and the light colored eyes is the oculocutaneous albinism which is given in this question. And along with this, there is mention of ataxia, which is the peripheral neuropathy, which is also seen in this patient, neurological association, which is also present, a derma association that is present. So you realize, okay, man, this is Shedek Higashi, the defect of LIST gene, where lysosomal trafficking is defective. So there's a defective phagolysosomal activity, and the neutrophils are not able to eat the bacteria, not able to properly digest the bacteria. So the correct answer in this question is option number B. So what I've tried to do is cover all the routine neutrophil related defects in a series of questions, so that if any one of them is coming, you are saying, bring it on, man, bring it on, right? So this slide is an important one that will be available subsequently to you. And what is not correct about chronic granulomatous disease? This is among the, I usually find like chronic granulomatous disease, everybody reads very well. So in this, I'm expecting the least amount of mistakes. You get infection with catalase positive organisms, Staph aureus, Burkholderia, those are the nasty organisms, catalase positive. This is the investigational choice for this condition, dihydrorhodamine test. It's a flow cytometry based test. It's a NADPH oxidase defect, the respiratory burst in this condition. The respiratory burst in this condition is defective. But this disorder is X-linked recessive. And if it is X-linked recessive disorder, it will be more common in boys as compared to that in the girls. So the wrong statement in this condition is option number D. Yes, guys, you're doing a great job hitting the comment button. That is more common in girls than in boys because the pattern of inheritance in this is X-linked recessive. So what I've done here is also mention the patterns of inheritance for each one of them. You can straight away answer autosomal recessive, but for Job syndrome, which was the first one we discussed, it is autosomal dominant. For chronic granulomatous disease, it's going to be X-linked recessive. And for LAD, remember, late umbilical cord separation is present. And eosinophilia is a hint which is always given in Job syndrome. I'll highlight the core points once again. I'll just take 15 seconds into it. If they talk about eosinophil count being increased along with recurrent infections, and obviously neutrophils are not doing their job, think in terms of job, though we discuss more also that A, B, C, D, E and the STAT3 mutation that we discussed. But like this is a quick hint to remember this. So another 5 seconds into this, delayed cord separation. If given in a question with recurrent infections in the clinical domain, you have to think in terms of LAD, CD18 is the problem in this case. Okay. So we move out of that part and now talk about antibodies. And this question I have already discussed with you in one of the previous questions related to anaphylaxis, that all antibodies are able to fix the complement like immunoglobulin G and immunoglobulin M. They are able to activate the classical pathway, and immunoglobulin A is able to activate the alternate complement pathway. But when it comes to not being able to fix, it is immunoglobulin E. Guys, it's immunoglobulin E. I said an antibody that cannot fix the system, then it is going to be immunoglobulin E. This antibody is also called as reagent antibody. The specific name to be remembered is reagent antibody. Abhi anaphylaxis mein bataya tha na, when we discuss anaphylaxis, immunoglobulin E was causing complement activation. Na? Immunoglobulin E does not cause complement activation. Yes, the correct answer to this question is option number C, and the antibody that I'm talking about is immunoglobulin E, that is related to the process of allergy. So good job. Next we are having, this is again a repeat from last time's paper. We are having a female, she's having a ptosis with diurnal variation. So when we read about, though Amitabh Bachchan has this disease, but then this time it's like a young female, and she's showing a diurnal variation of her weakness, and the CT shows a anterior mediastinal mass with a thymus gland cancer. So the disorder we're talking about is myasthenia gravis. Now myasthenia gravis is a pre-junctional defect in which acetylcholine will not be able to act. Right? Acetylcholine will not be able to act. So what are the receptors at the neuromuscular junction is the basic science that they're talking about. I could see a C coming up. You see, guys, I think I have explained this even in medicine, that antibodies against voltage-gated calcium channels, that is a separate disorder, Lambert-Eaton. Against that voltage-gated, no, that is Lambert-Eaton, which is a pre-junctional defect where the acetylcholine production will become relatively lesser. That's a pre-junctional defect. The question is regarding a post-junctional defect. Guys, the antibody in myasthenia gravis acts against which acetylcholine receptor? It acts against not acetylcholinesterase activity, but it does not act on the disintegrating enzyme. It does not act on the enzyme. It acts on what? It acts on the receptor. You have to select. You see, myasthenia gravis, if I say in Hindi here, pardon me for just using my two words there, भाई disease क्या है? Neuromuscular junction में receptor damage हो जाता है. The antibody affects the receptors. So C and D are totally off the radar. It is the receptor that is to be involved. And do you have muscarinic effect? Do you have something like sweating and like, you know, say alluria developing in this patient? No. So it is nicotinic receptors that would be involved. The correct answer to this question is option number A. And believe me, it took me a lot of time to be able to figure out this question from the recall. I mean, this question took me like almost like maybe 15 minutes by multiple interactions to be able to figure out the final set of options that I've currently mentioned here before you. Guys, myasthenia gravis is a disease affecting acetylcholine receptors. I think we are even on that acetylcholine receptor. Now it is left between only two, nicotinic or muscarinic receptors. So when you read the word muscarinic, right, you read about like secretions, right? Here we are not talking about any secretions. We're talking about neuromuscular junction. So it's going to be nicotinic receptors which are going to be affected. The antibodies which are present here are called as anti-acetylcholine receptor antibody. Hit the comment button. Tell me the second antibody in myasthenia gravis. Hit the comment button for the second antibody in myasthenia gravis. Very good. Okay. Guys, it's just that paper is occurring in English now. So like what I'm trying to say is, because I'm happy to use mother tongue. That's never an issue. It is just that paper is occurring in English and they're putting twisted terminologies. So that is why like I'm trying to focus it more of English oriented. Otherwise though, there's never an issue. Okay. For high eosinophil, Churg-Strauss, Ankur, Churg-Strauss will be having asthma and peripheral neuropathy, right? So it's not, Churg-Strauss is not alone based on asthma-like manifestations, no. It would be peripheral neuropathy that could be coming. There could be mononeuritis multiplex that could be happening. So multiple manifestations there. Yes, Vimal came up with a very good answer. Anti-LRP4 antibody. I mean, excellent guys, you're doing a great job. So all of these antibodies, they damage the receptors. So answer would either be A or will be B, and the correct answer is option number A. Anti-musk is a very good answer. Cool. So we talk about an Indian scenario. This farmer is coming back from the field and like in the dark, because lots of time on the roads, etc., snake might be crossing the road. So accidentally like this person's foot went over the snake. Normally like snakes are afraid of humans. They don't want to interact with humans, so they will run away. Like if you've ever been to a village, or like I belong to a village, so like seen a lot of snakes. So what I can say is like this particular person was bitten by a snake, and when he's brought to the community health center, there is ptosis and difficulty in counting up to 10. Like you and me can count fast, no? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 like that. Here diaphragmatic weakness. So therefore, what I am thinking on the basis of the clinical profile of neurological weakness given in a question is the guy is having a cobra bite, and the doctor on duty has given 20 vials of anti-snake venom, and now is coming back to us with rashes all over his body, joint pain and fever. And the presentation that I described before you with anti-snake venom, which is usually derived from a horse, would be serum sickness. This particular person is having anti-snake venom induced. This particular person is having a anti-snake venom induced serum sickness, and serum sickness would be an example of type 3 hypersensitivity reaction. Type 1 is anaphylaxis, so it is ruled out. For type 2, I would like to give a standard answer that is always asked. IgM class of antibodies play a role, that is mismatched blood transfusion. This is by immunoglobulin M antibody. In anaphylaxis, it is IgE antibody, but it is related not to eosinophil but to basophil. And for type 4, we anyway know lepromin reaction, Mantoux reaction, and type 4 or delayed hypersensitivity will come up in the discussion multiple times. Like you read about patch test, lepromin test, or Mantoux test. All of those are going to be type 4 hypersensitivity reaction, but type 3 is going to be like serum sickness. So therefore, this would be a type 3 hypersensitivity reaction that's occurring in this guy after a snake venom, anti-snake venom induced serum sickness occurring in a patient. The correct answer is option number C. And anti-snake venom will be having, the anti-snake venom dose in children and adults is equal, because it's not based on weight. Giving anti-snake venom is not based on weight. It is based on, like, the snake would have injected the same amount of poison, whether the child is bitten or adult is bitten. Like the amount of poison going in the body of the patient is equal. So the number of vials that we require for giving anti-snake venom in adults and children is equal. Yeah, type 1 would be drug induced. Dr. Mishra, you are right. Moving to another question on hypersensitivity reaction. This guy is having lepromatous leprosy. Lepromatous leprosy is where you lose your eyebrows and eyelashes. You get manifestations of madarosis. Eyebrow hair is lost, eyelashes are lost, saddle nose can be present in a patient, and the patient is having these painful nodules on the skin and joint pain and swelling 3 months after taking the multi-drug therapy, clofazimine, rifampicin. The standard treatment that we give has been given in this patient, and that is when the problem is starting in this guy. So what you have to pick up is, yes, I'm waiting for your answers here. Yes. First and the foremost is patient is having lepromatous leprosy and is having a lepra reaction. So what is the lepra reaction which is present here? It is type 2 lepra reaction. That is called as erythema nodosum leprosum also, ENL. So it is a type 2. In lepromatous leprosy, we get a type 2 lepra reaction, that is one. And type 2 lepra reaction, right? It is type 2 leper reaction that will be seen in a patient, but this will present with fever, and there would be like painful nodules, and there would be like swelling, systemic symptoms, even orchitis developing in a patient. This would be a manifestation. It is a type 2. Question is asking about hypersensitivity reaction. Question is not asking about what is the leper reaction. Question is asking regarding what is the hypersensitivity reaction. The hypersensitivity reaction that is seen here is type 3 hypersensitivity reaction. Now, how to remember this? Well, to remember this, I can say that if I am a student and if I travel by first class, right? So I would like to give like lot of stars, I would like to give a lot of stars to the airline. Like you are traveling by any airline and they let you fly. Okay, sir, today you're not flying economy, you go first class, right? Or business class. So you would give more stars. So that would be like 1 + 4, right? So type 1 hypersensitivity reaction, type 1 leper reaction is type 4 hypersensitivity. That is what we see with borderline type of leprosy. With borderline type of leprosy, it is type 1 leper reaction. BB means borderline type of leprosy. That is 1 is the leper reaction and the hypersensitivity is type 4. And yes, here it is gonna be like second class से travel करेंगे तो कम से कम 3 complaints तो आदमी बोलेगा. जगह नहीं थी, टॉयलेट साफ नहीं था और खाने को कुछ नहीं मिला. If we ever travel by second class in India, there are 3 complaints that always people will say. One is there was no air conditioning. Right? It was stuffy, it was hot, it was stinky, washrooms were not clean, and I did not get anything to eat. So second class, when we are traveling, there is bound to be like 3 complaints usually seen in people. So that is type 2 leper reaction. Type 2 leper reaction would be related to type 3 hypersensitivity. So you need to figure out ways to remember this. Yeah, rule of 5, I mean, I could have said rule of 5, but then 5 se na hota kya ki both errors can come in. So I think with this visual representation, because see, at some point of time in our life, our parents may not be having so much of money as they might be having today. So all of us would have traveled by train sometime. So when you remember second class, it's a nightmare to travel by second class at any point of time. So there's bound to be complaints. So that's like one way to remember it. So 1 + 4 is 5, 2 + 3 is 5. And what you need to remember is this particular guy is having lepromatous variety of leprosy. So it was like more of a clinically oriented question with a bit of pathology coming in. And therefore the correct answer for this question would be option number C. How to know it's a type 2 leper reaction? Type 2 leper, doctor, it is seen with lepromatous leprosy when the treatment is started. If it is borderline, if it is written BB, BT, BL, if it is borderline word given, then it is going to be type 1 leper reaction. And if it is lepromatous, and why I'm saying is because lepromatous will have more bacterial load. Na? So more bacterial load will contribute to when you kill those bad guys. The inflammatory cytokines will cause aggressive manifestations. That's like skin and joint pain and the manifestations that are seen here. So the pickup point in the question is first read what type of leprosy is given. And once you know like what is the type of leprosy that is given, then subsequently you can pick up the manifestations also, and then you need to do that mathematical formula and you will be on your way to solve the question. The correct answer in this case is option number C. I hope it makes sense, guys, at this particular point of time, that when you travel first class by airlines, you would give lot of stars, right? I mean, you'll try to give 5 stars to the airline. You'll say, oh, thank you so much, you upgraded me. If you travel by second class, that would be like 3 complaints. So I mean, that's one way of remembering. If you have an alternative way of remembering, it is perfectly okay. I mean, but this is like one approach that I think can help in work in this case. If it was only a snake bite, doc, snake bite will cause death due to neurotoxicity, no? Snake bite will contribute to death because of the neurotoxicity component. Okay. I just need to decrease the speed of the fan because it's being caught by the mic. Okay, so we are sorted for 24, guys. Let's move on to the next one. Garmi ho gayi yaar. Fine. So again, a repeat one. 65-year-old man presents with progressive anemia and cervical lymphadenopathy. The peripheral smear shows that very classical smudge cells. It shows that very classical smudge cells, and the diagnosis in this case that you will be keeping is one of the commonest cancers that we see, that is chronic lymphocytic leukemia, that is CLL. The highlight of chronic lymphocytic leukemia is that seen in geriatric population, and you don't need a bone marrow aspiration for it. The cells which are present here are fragile, immuno-incompetent B cells. The highlight of chronic lymphocytic leukemia is, I'll use a Hindi word, nalayak bacche hain. Right? So incompetent B cell, bone marrow परेशान है, कह रहा है यार ये नलायक है, incompetent, immuno-incompetent, आपस में लड़ते रहते हैं, they keep on fighting with each other. These immuno-incompetent B cells, they're attacking self-RPC, they're attacking their cousin brothers and sisters. When I say immuno-incompetent B cell, it means that the B cell is attacking RBC. It is attacking platelets. They're attacking their own siblings. They're attacking their own cousin brothers and sisters. So you have as an autoimmune hemolytic anemia occurring in this patient. You have as an autoimmune thrombocytopenia occurring in this patient. In no other blood cancer do you read about cancer cells affecting white blood cells, killing the white blood cells. Here we get autoimmune thrombocytopenia, autoimmune hemolytic anemia, which is present in this case. I think all of you have read regarding the word Evans syndrome. That Evans syndrome is going to be autoimmune hemolytic anemia and autoimmune thrombocytopenia combination that can be seen with these patients also. That is called as Evans syndrome. Very good, Nikhil. You were the first one to comment on that. And how do you diagnose CLL was the question in the last time's FMGE exam. It is a peripheral blood flow cytometry. This is a pure B cell tumor that expresses CD5. The B cell markers would be 19, 20, 23, but along with that, there would be expression of CD5. The correct answer to this question is option number C. The investigational choice for chronic lymphocytic leukemia is not a bone marrow aspiration. It is a peripheral blood, and on peripheral blood, we can go ahead with flow cytometry that would give these following reports of B cell markers with aberrant CD5 expression. It is flow cytometry on PB, that is peripheral blood. Quick comments in the chat box. What is the investigational choice for chronic myeloid leukemia? Where we get that Philadelphia chromosome, where we get that BCR ABL1 mutation. So what test can be done for diagnosis of what is the best test for diagnosis of chronic myeloid leukemia so that you can pick up the chromosomal translocation? Okay, I had very good answer. That is FISH, fluorescent in situ hybridization. That is FISH, which could be done on the bone marrow specimen of this patient, or we can do a PCR also, but PCR will mainly be done for BCR ABL transcripts, and it will help in determining the response to the treatment that you're giving. So if I change my question and say like, okay doctor, tell me what investigation in chronic myeloid leukemia will be helpful in identifying the response to the treatment, then it is PCR. But for initial diagnosis in this patient, it would be a fluorescent in situ hybridization on the bone marrow specimen. For response, it is PCR to be given. But for chronic lymphocytic leukemia, the immuno-incompetent cells, the null-like cells were coming in the bloodstream itself, attacking their cousins, brothers and sisters. So peripheral blood flow cytometry would be helpful in diagnosis of this condition. As far as acute myeloid leukemia and acute lymphoblastic leukemia is concerned, the investigations for those and the prognosis related to various chromosomes would be discussed subsequently. So at the moment, I'll restrict myself to two of these that I've currently mentioned. And overall, the most common blood cancer in adult population is chronic lymphocytic leukemia, not chronic myeloid leukemia. This is again a repeat question, guys. A 12-year-old patient comes with fever, weight loss and a painless cervical lymphadenopathy. So the moment you read about that painless cervical lymphadenopathy, you're thinking either it could be TB or it could be a lymphoma. And then the highlight which is given here is presence of hallmark cells. Now, how the hallmark cells would look like is that they'll be having a nucleus which is going to be very peculiar in shape, like the shape that you can see at the moment, like a horseshoe that you can see at the moment. So the hallmark cell is that C-shaped or like that horseshoe shaped nucleus that is present, and this is a feature of anaplastic large cell carcinoma. In fact, they wrote it themselves only, anaplastic large cell carcinoma. The chromosome donut is an alternative term for that, would be translocation 2-5, and the remaining options will help us because A14 is for Burkitt's lymphoma, 814 is also for Burkitt's lymphoma, and 1418 is for that Frandl lymphoma, that is follicular lymphoma. So it is 2-5 by exclusion as well. We just had to work out our options properly. That would be 2-5, that is anaplastic large cell carcinoma, 1418 for follicular, and then the remaining ones for Burkitt's lymphoma seen with Epstein-Barr virus, where we get that classical starry sky appearance. Okay, we sorted for 26th. Let's move on to the next one. We have this boy, he came with ingestion of paint chips. and soil. So there is some history of pica also, but along with pica, like there is pica would imply non-edible substances being consumed, and there are paint chips which are present. And then inside the RBCs, you can see that very classical Pappenheimer bodies that are present, or basophilic stippling that is present. So the moment I pick up that Pappenheimer bodies, I know my answer in this case would be given as lead poisoning. Everything else would go out of the window because the peripheral smear finding in none of those would be exhibiting those blue spots that can be seen in the current image that I've currently shown before you. Yeah, penterscolic is another term that can be used here, though nowadays like the lead paints have become relatively lesser. Let's mark these slides as A, B and C. For A, B, first for A, please comment. Like you can see this, normally RBCs lack a central pallor. Normally, red blood cell will be lacking a central pallor. Here you can notice the target sign which is present here. So the moment you are able to see the target sign, like there's so many red blood cells with the target sign present here, which hemoglobinopathy are we talking about? Yes, what we're talking about is target cells which are seen with respect to hemoglobinopathy that we're suspecting is thalassemia. It could be beta thalassemia, it could be alpha thalassemia. Beta is related to chromosome 11 and alpha is related to chromosome number 16. Now when you compare this with the next slide that you are currently seeing, then you can see that cells are adopting various shapes. Like there is anisocytosis, there is poikilocytosis. Like we always compare RBCs with a small lymphocyte. This is the reference cell. Like pathologist will compare RBC with respect to which cell. So the pathologist will check out the small lymphocyte in the blood. If RBC is smaller, chota, than the small lymphocyte, then he will say microcytic. If it is bigger than a small lymphocyte, then you will say it is macrocytic. So what you can see in this case is that the large number of RBCs which are smaller and they're adopting various shapes also, pencil cells, like this is like more of oblong that would be present. So because I'm having that anisocytosis, poikilocytosis, the variation in the size and shape, then it would be iron deficiency anemia. And for the extreme right hand side, we'll be having a condition where there would be sideroblastic anemia developing in a patient that would be related to lead poisoning, where there would be Pappenheimer bodies that can be present. So at this particular discussion, I just want to compare the three slides that I mentioned before you for a hemoglobinopathy, iron deficiency and lead poisoning. Hit the comment button and let me know what is the investigational choice for thalassemia. You want me to give options also? Okay, I will give you options also. Hemoglobin electrophoresis, HPLC, gene sequencing. Quick comments. What is the investigational choice with respect to thalassemia, whether it is alpha or beta thalassemia, guys? Okay, I am getting very good answers at the moment. HPLC, great. HPLC, high performance liquid chromatography. Then I'm getting hint like hemoglobin electrophoresis as well. Guys, मैंने बहुत बार बताया है that the investigational choice for any genetic disorder nowadays is gene sequencing. It is not HPLC, it is not hemoglobin electrophoresis, because they can be errors. They can be errors in the reports. The best test for diagnosis, please add this to your notes. The investigational choice for diagnosis of thalassemia is gene sequencing. What gene is involved in beta thalassemia, by the way? Gene involved in beta thalassemia without any internet usage. Can somebody comment? Yes, it is next generation sequencing. It is gene sequencing, guys. If this is not in the options, then answer is high performance liquid chromatography. If this is not in the options, then the answer is hemoglobin electrophoresis. So not that you are wrong, but we have to select the single best answer for the paper. No. So therefore the best test for diagnosis would be given as gene sequencing. And what is the gene that is involved here? The gene would be HBB. No, bache, it is HBB gene that would be involved for beta thalassemia. It is the HBB gene for beta thalassemia. Please add this to your notes. Most guys carry that wrong notion. The best way for diagnosis of thalassemia, sickle cell anemia, or like any hemoglobinopathy would be for any genetic disorder nowadays. It is gene sequencing that would be done. Then would be hemoglobin high performance liquid chromatography, and then is HB electrophoresis in decreasing order of importance. What is the treatment of choice for thalassemia, beta thalassemia or alpha thalassemia? Yeah, osmotic fragility in this condition will be reduced. In hereditary spherocytosis, osmotic fragility is increased. Here, osmotic fragility would be reduced. So, what you're trying to say is that, sir, the screening test for this condition is naked eye, single tube, RBC osmotic fragility test. Agreed. The osmotic fragility in this condition would be lesser. What is the treatment of choice for thalassemia? You want me to give options? Okay, blood transfusion, packed RBC with iron chelators, bone marrow transplantation. Yes. Okay, blood transfusion is one of the chart that is coming up. Blood transfusion is coming up. Guys, blood transfusion नहीं करते हैं, packed RBC करते हैं. Does this patient need platelets? No, na. This patient does not need white blood cells, no. We don't need to waste blood. We can use to save somebody else's life, no? Now it's gonna be raining in India. After that, the dengue will start, so we need to save the platelets. So for survival, we give packed RBCs, but the treatment of choice is bone marrow transplantation. If he says treatment of choice for this condition, then it is always gonna be answered as allogenic bone marrow transplantation. And for all of those who are tuned in at the moment and are listening to this discussion, my message to you is 4 points. For every disease, I suggest you, since you've joined the program, is you need to make a separate register. For every disease that you study, you should know cause. You should know the main presentation, the investigation of choice and treatment of choice. You want to learn more than that, I'll be so happy. But for every disease that you read, if you know why it happens, what is the presentation of it, what is the investigation of choice, and what is the treatment of choice, you are sorted. In whole of pathology, medicine, surgery, OBGY, if you look at the entire thing, there are hardly 150 diseases. If you multiply that by 4 points, how many points is it? 600 points. Are they too much to remember? No. Whether you are a first attempter, whether you are a second or a third attempter, doesn't matter. At this moment, what I am telling you is in entire medicine, surgery, OBGY, and pathology, because there would be repeats of medicine component also present there, and surgery sometimes also, there would be like 150 topics. If you're good at that 150 topics, you are sorted. When I say like this, the query of lot of doctors is that, sir, why don't you give a PDF then for 150 diseases? Why? If I give you that PDF, you're not gonna read it, you'll keep it in a mobile phone. But if you make that list every single day in your own handwriting, one disease you read, right? You're reading thalassemia with me, no? So you know the presentation, chipmunk faces, hepatosplenomegaly, anemia will be there. But along with that, you need to know the IOC and the TOC. Without that, guys, the study is incomplete. We assume we have read a topic. You might be reading thalassemia the whole day, but if you cannot answer the treatment of choice, no benefit of studying, no. So are you reading consciously? Are you reading with insight? Is what I'm trying to teach you. What the objective of the session is to let you know that every question that you attempt is based on how carefully have you read a topic. Cool. We'd give iron chelator, man. We give iron chelators, but that's not like the treatment in this particular condition. So let's move on. Bernard-Soulier syndrome. Bernard, if you've seen dogs, you know, though like recently in Delhi there has been like a lot of people fighting about dogs, but like Saint Bernard as a species, you will notice is like a very, very big dog, and in a similar sense, like I can say, Bernard-Soulier syndrome will be having giant platelets, and because these platelets can be as big that they are like as big as sometimes as big as lymphocytes, so sometimes you might be getting a pseudo increase in TLC. The total leukocyte count of this patient can be increased because, as I said, Bernard name tells you that, you know, the Bernard species, Saint Bernard species is like a big dog. So it's going to be giant platelets, and these giant platelets can be misread by the Coulter. Coulter is that machine that basically analyzes the platelets and the white blood cells based on their size. Coulter machine is the machine that basically is able to measure the size of the RBCs and the WBCs and the platelets. And some of the platelets in this condition can be so big that they can actually be looking like a white blood cell, and therefore the machine might be giving an erroneous report of a TLC being increased in a patient. Bernard-Soulier syndrome is a problem of sticking of the platelets. It is big platelets and they don't stick. Now, when they don't stick, the addition part is defective. This question that you need to remember is like in Bernard-Soulier syndrome, what is the primary defect? What is the platelet glycoprotein that is affected? So this would be group 1B 9 complex, that would be affected. The answer for this would be option number B. And if you're saying option number A, then that is for a condition that is called as Glanzmann thrombasthenia. At this moment, also a message for everybody who's tuned in, read platelets very well. When you read hematology, no, don't start with RBCs. Most guys start with RBCs and you tire out by the time you reach WBCs, and platelets are the most neglected part, but they put up a question on the same. This would be Bernard-Soulier syndrome. It is a problem with respect to adhesion. This group 1B is responsible for platelet adhesion to the wall, whereas 2B3A is responsible for platelet aggregation. We use medicines in cardiology, no? Like we use drugs like, we can use drugs like Cangrelor. They are used in non-ST elevation MI. They are group 2B3A platelet inhibitors. They inhibit platelet aggregation. I mean, I'll not get into too much of pharma of this because we are not doing an integrated discussion of pharmacology at the moment. It is medicine and path that should be done. If you mix up the three, no, then it becomes a mishmash. No, then yaad nahi rehta. So it's always med and path that can be combined. But we don't make, like, obviously we'll discuss pharmacology also. But if you mix 3 subjects, no, you can mix 2, man. Don't mix 3. My suggestion to you, when I've gone through the stages as yours of uncertainty in my undergraduate days, ki kya hoga tomorrow, but mixing of too many subjects would always result in, like, you can mix 2, man, and that's understandable, logical, but you're mixing 3, that will become like mishmash of everything. Okay. Yeah, path pharma make medicine. True. But it's not vice versa, no? Medicine does not make path and pharma, no? So one subject does not replace the other one. Bernard-Soulier syndrome will be having large platelets that are having an adhesion defect. And what I mean by adhesion is adhesion with the tissue glue. What is the tissue glue? The tissue glue is von Willebrand factor. And because of this tissue glue adhesion, like, the problem is not the deficiency of von Willebrand factor, it is the platelet that is lacking 1B receptor that I was talking about. Bernard-Soulier begins with the B, and it is the 1B receptor which is to be remembered. Pretty straightforward, man. It is 1B. Bernard-Soulier 1B receptor that is responsible for the platelet adhesion part that is affected. The restocin aggregation test in this condition will not show correction with plasma, so that's okay. But most of the time they're not even reaching up to the restocin aggregation. They're reaching on the common thing, which is like, what's the fundamental problem in Bernard-Soulier? So remember, large platelets, sticking problem. Bernard begins with a B, so it's like I can say that 1B receptor is the one which is affected here. Okay, moving on. Small platelets are seen in Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is X-linked recessive again. So we'll discuss a mnemonic later on for the X-linked recessive disorders. But Wiskott-Aldrich would be having small platelets. Bernard-Soulier will be having like jumbo platelets or super large platelets present. Now we come to the favorite question of yours, which everybody would love to answer. Congo red staining showing a apple green birefringence. The moment I say apple green birefringence, everything else goes into retrospective. No, periorbital edema, massive proteinuria, and hypoalbuminemia. The most common organ involved in amyloidosis happens to be the kidney, and it causes a nephrotic range proteinuria. So the most likely diagnosis in this case is very well sorted. The answer is option number A in this. And I think I did not have to even explain this question. The moment you read regarding kidney biopsy showing an apple green birefringence, polarized light, you knew the answer to this question. So I have another one for you. What is the common organ involvement in amyloidosis that leads to death? You get nephrotic range proteinuria, that is understandable. And a Pakistani general, you know, we call him the butcher of Kargil. In 1999, India was attacked, right? We had a post being occupied, and at that time we did not have any laser-guided bombs, etc. So we had to send in troops, and we lost 500 soldiers to enemy fire in our country, right? We did not invade a country. They came in our country and killed our boys. General Parvez Musharraf, the Pakistani general, he died because of amyloidosis, and the involvement is that of restrictive cardiomyopathy, RCM. The most common organ involved is amyloidosis, is kidney. And then you can remember the example of General Parvez Musharraf from Pakistan. He was the one who was instrumental in ensuring the Kargil war happened. And he died himself because of restrictive cardiomyopathy in a Dubai hospital. Okay. The correct answer for this question is option number A. And then I've given you 2 more additional questions on this topic. So I think we are sorted for this one. Moving to the next one, we have a a phenotype of upward slanting palpebral fissures with hypotonia. So initially I thought it could be any of these syndromes, but then he himself mentioned a 5p deletion that is present here. So Edward is rated to 18. So it's ruled out anyway. Down syndrome is rated to 21. Pathology is rated to 13. So this would be Credue-Chart syndrome. Credue-Chart would be where the baby will be, when he is crying, it would be like the cat's baby is crying. So mewing kind of a sound would be coming with respect to this question. The rest are a trisomy, yeah, and this is a deletion. So one is the way to solve it is the trisomy component. The trisomy component coming up again and again. And here there's a deletion that is happening, so that's one way to crack it. Or it would be simply the 5p deletion part, which can help you in remembering this, and then the couple of salient features for each of them that can be remembered. Okay, a question for you guys, since this was a easy liking. What congenital heart disease is seen in patients of Down syndrome? Options are ventricular septal defect, common as seen, ventricular septal defect, atrial septal defect, ostium secundum, atrial septal defect, ostium primum. Select among the three. You can answer as the full names itself, VST, AST, ostium secundum, OS you can write, or for ostium primum you can write OP, ostium primum. Yes guys, in Down syndrome patient, what is the commonest heart disease that is encountered? Overall is ventricular septal defect. Overall is ventricular septal defect, right? Overall is ventricular septal defect, that is understandable, but in patients of Down syndrome we have what is called as endocardial cushion defect. This endocardial cushion defect is also called as AV canal defect, and I deliberately changed the options. The options for you would be ostium primum. In patients of Down syndrome, the defect that is present is endocardial cushion defect, that is okay, but lots of time in questions they may not mention the exact option. You might say ostium primum and ostium secundum. Overall, most common type of AST is ostium secundum, that is okay, but in Down syndrome baby, it is ostium primum. The alternative name for that is AV canal defect and is also called as endocardial cushion defect. So I hope that makes sense here, and I'll repeat the statement once again, quick 15 seconds for those who are maybe a little casual in this. The most common congenital heart disease overall is ventricular septal defect, no challenge to that. But in Down syndrome, we get heart failure. And that heart failure occurs because of AST, which becomes symptomatic very early. Normally AST presents in adult age group. When I say like this, no, the query of most people is, sir, AST presents in adult age group, then how in children? Because the variety that is present here is not ostium secundum. The variety that is present here is ostium primum variety. So additional point has been thrown in for you to remember, to ponder about, that the heart disease that is seen by Down syndrome is Down syndrome. With Down syndrome is going to be endocardial cushion defect, alternatively called as alternatively caused as AV canal defect, or alternatively called as ostium primum as well. Okay, gynecology / pathology based question. A lady came with lower abdominal discomfort. There is no vaginal discharge, like he has ruled out PID, pelvic inflammatory disorder. Because one of the common reasons why, like in India, a woman from low socioeconomic state of society will come to you is because of PID, chronic PID caused by chlamydia, and there would be tubo-ovarian masses, but he has himself written like there's no vaginal discharge, so PID has been ruled out. Ultrasound showed a ovarian mass, and then we did a resection, and you can see the teeth and you can see the hair. So there's a well amount of differentiation that is present here. So this is a dermoid cyst, this is a mature cystic teratoma. The mature word is coming because you can see endoderm, ectoderm, mesoderm derivatives which are present in this case. I mean, there's a well differentiation because teeth can be seen, teeth can be seen, hair can be seen. So there's like a well differentiation occurring of the tissues, and that is why the answer in this case would be a mature cystic teratoma. The main thing is all kind of derms would be involved here, ecto, endo, and the mesoderm. Hit the comment button with respect to what is overall the most common benign tumor of the ovary. Waiting for your answers, and do take care of the spellings there. The most common benign tumor of the ovary would be, yes guys, benign tumor of the ovary. Okay, so a couple of people did use a couple of short terminologies there, but yes guys, I mean, which is gonna be like, I would say like, the benign tumor, right? And then we're going to talk about the malignant tumor also. Quick answers, please. Yes. The benign tumor is going to be a serous cyst adenoma. And if I say adenocarcinoma, then it will become the malignant one. So I was just looking for the terminologies there. But if I change the question to that of germ cell origin, if I change the question to that of benign tumor or germ cell origin, then the answer would be yes, serous cyst adenoma is the answer for benign tumor. For germ cell origin, guys, quickly. We are discussing it already, man. We are discussing it already, right? When I'm saying the word germ cell tumor, then we are thinking in terms of a teratoma. Very good. Like there was a lag here. This would be a teratoma. Now it's the malignant tumor. So malignant tumor would be answered as serous cyst adenocarcinoma. And you can quickly comment with respect to the last question that I put up here. That is with respect to germ cell origin. Some people have already answered that already, but they answered it for benign. You know, germ cell origin is a teratoma, the benign one. But if I say germ cell origin, then it's going to be dysgerminoma, no? Dysgerminoma cells are identical to that of seminoma, no? That fried egg appearance that is seen. Dysgerminoma and seminoma are like counterparts, no? Seminoma would be seen in the testes and dysgerminoma will be seen in the ovary. So what I want to bring to your attention is that the benign one and the malignant one, nobody will have a problem because the answer is serous cyst only. But it is adenoma versus adenocarcinoma, so nobody has any issues with that. But in some questions, they have been in previous years, like they put the word germ cell origin. When you have a slight change in data, that would be teratoma is a benign one, that's a mature or an immature one. Immature means differentiation of tissues will not be there, and in a mature one, the differentiation of tissues would be very much be present. So this would be a dysgerminoma. Great, Satish, you came up with a very good answer. Okay. This was a long stem question. I mean, reading this question in the actual paper took almost like 90 seconds or so. We are having this girl, she's having a fever, headache and purpuric rash, and then we had to do a lumbar puncture in a patient because of the fact that there is headache and nuchal rigidity along with fever. The triad of meningitis is getting satisfied. Fever, headache and nuchal rigidity. Now the lumbar puncture is revealing the standard features: turbid CSF, low glucose, elevated protein, 1000 neutrophils. So examiner was wasting my time by making me read these lines. Then there was a gram stain saying gram-negative diplococci. That gram-negative diplococci would be basically meningococcus, because overall you are aware that the most common cause is pneumococcus, but here because it's saying the word gram-negative, so we are talking about Neisseria meningitidis. The funny thing about the question was that he did not even ask the diagnosis. He said, patient has had multiple episodes of meningitis, and the first time I read it, I'm like, is it crazy, man, that person has had multiple episodes of meningitis earlier? And then it strikes me, yes, man, repeated episodes of meningococcal meningitis are seen with patients who are having problems with membrane attack complex. And what is membrane attack complex? It is C5 to C9 deficiency. The correct answer for this question would be option number B. This is a one-liner question that used to be asked in your exam in earlier time, that membrane attack complex / complement C5 to C9 deficiency causes which type of which organism causing meningitis on recurrent basis? Meningococcus. What he did this time was he made it a long story. Right, described the entire meningococcal meningitis, wasted everybody's time, energy was sapped out by the time like people reached the last line. So when you get a 4-5 liner MCQ, then do try to read the last 2 lines, and you obviously have to read from top to bottom only. But while reading fast, you need to get a habit of like picking up a couple of lines, because see, here the most important thing was what I have highlighted, and I'll just do highlighting once again: multiple hospital admissions in the past for bacterial meningitis. I mean, if I catch that line right in the word go, I can save 30 seconds of my time. You obviously have to read the whole question. I agree to that. But then, like, had I read this line right away, then my chances of striking this question right would have been perfectly okay. Then another condition that is mentioned here is Bruton A-gamma globulinemia. In this condition, as the name suggests, B cells would be totally absent. I mean, normally B cells are for antigen detection and subsequently help in humoral immunity. And here Bruton tyrosine kinase enzyme is the one which is affected, because of which like the B cells are completely absent. So the immunity levels in the patient would go down. So even repeated infections can be seen. But then when it comes to repeated meningococcal infection, the movement, the word meningococcus infection, how did it reduce it? The word gram-negative bacteria, gram-negative diplococcus. If he spoke about gram-positive, then it is Pseudomonas, and he says gram-positive Diplococcus, it is not Pseudomonas, Pneumococcus, but if he says gram-negative Diplococcus, then it is Neisseria meningitis. Okay. Answer to 32nd is B. Let's move on to the next one, and the cartoon that I made is gonna help you solve this question very easily. Opsonins are like they're gonna make the bad guys, the bacteria, tasty to the security system. So this is a phagocyte. This is a macrophage, and he's very happy to eat the bacteria. He's finding the bacteria very tasty because it is coated by all chutneys, and the chutneys are like immunoglobulin G and complement and mannose binding lectin, as we used to study in our undergraduate days. So like which is not gonna be a component, then not a component of opsonin, not the chutney over the bacteria to make it tasty would be complement 5A, that is anaphylotoxin. This is mainly responsible for chemotaxis. This is called as anaphylotoxin, and this anaphylotoxin, the main function of this complement 5A, guys, it is an accept question. If you are making mistake in this one, then this is complement system, please read again. Complement system, please read again if you're making a mistake in this one. Like I said, it is not the subject that is weak, it is the topics in the subject that are weak. Here it is like this would be responsible for chemotaxis. This will be like sending the invitation, come. But it's not gonna be that chutney over the food product that's gonna make it a little more tasty. Like that, I can say opsonin is gonna be like making it more palatable for the security system to consume the bad guys. Yeah, chemoattractant is what you can say. Chemotaxis is what you can say. The answer to question number 33 is option number delta D. And like if you got it correct, cool. If you got it wrong, then please do practice the complement system in detail. And if you get these questions right, like I mean, this is retrospective way of studying. Prospective is you read the notes and then you do questions, but retrospective is you do a question, the one that goes wrong, you go back to the notes. So make a mark in your notes. Okay, this topic, I did not score well. These subtopics at the end of this discussion, since you've been persisting with me for like almost substantial 2 hours at the moment. So what I want you to do is, just make a note of all the topics that are going wrong. And with that, I think the strike rates of yours would increase. Okay, coilocytosis is caused by which of the following conditions? Yes, guys, don't be passive. Hit the comment buttons. Okay, great. Coilocytosis. So one we read about right, one we read is coiloonychia, and second we read is coilocytosis. Coilocytosis is one that is seen with human papilloma virus. It is the infected cervical epithelial cells. This is a finding that is seen on a pap smear. This is a finding that would be seen on a pap smear. Like in this pap smear, what is shown in contrast is that these are like the normal epithelial cells, the shed epithelial cells related to the cervix. It is exfoliative cytology that I'm talking about, that is normal epithelial cells. But the ones which are infected by human papilloma virus, 16 and 18, those cells are going to be relatively bigger. And not only are they going to be bigger, the nucleus of that will also be much more like denser in color, much more blue in color. So those are the infected cells that are present. So this presentation that I mentioned before you is called as coilocytosis. That is the infected cervical epithelial cell, which is much more bigger in size and has a more basophilic nucleus, a much more basophilic nucleus caused by HPV 16 and 18. Related MCQ which I just want to mention before you is for human papilloma virus 6 and 11. This has not come in this recent paper, but there is always an image prior to this. In all your exams, there is always an image of either a man, and they might mention that the person is a homosexual, and they might mention person had unprotected sexual exposure, and because of that there would be like lesions on the anus of a patient, or like one session they mentioned the lesions on the vulva of a female. That would be condyloma acuminata, and that would be like HPV 6 and 11. So yeah, in the subsequent discussions that I'll have, we'll talk more details with respect to condyloma acuminata and condyloma lata, but this was a miscellaneous fact which I wanted to say for condyloma acuminata, either the anal warts or it could be vulval warts as a description. We'll also read the treatment of that, treatment in pregnancy, right? They've asked like a lady is having vulval warts, what is the treatment in pregnancy? But that's like in the later part of our discussion. Later part means subsequent discussions, like when we do dermatology, that's when we are going to talk about it. The next thing that I want to bring to your notice is coiloonychia. the condition, everybody can hit the comment button, will contribute to which cancer of the esophagus. I don't want the diagnosis. I know all of you know the diagnosis. I want to ask you that a person is having cholionicia with upper esophageal web. Then what kind of cancer of the esophagus can be seen? You can see that there is upper esophageal webs that will cause dysphagia. There is a iron deficiency anemia, and sometimes there might even be beefy tongue. Instead of writing the word beefy tongue, he may write the word glossitis. Yes, we're talking about Plummer-Vinson syndrome. And in Plummer-Vinson syndrome, because upper part of the esophagus is being talked about. Yes, guys, I'm waiting for the comments. Yes, in Plummer-Vinson syndrome. Yes, guys, in Plummer-Vinson syndrome. Yeah, there would be iron deficiency anemia. In Plummer-Vinson syndrome, which cancer would be expected? So because we're talking about esophagus, we're talking about the upper part. So the cancer that has to be suspected here is or can develop in this patient is squamous cell cancer of the esophagus. Plummer-Vinson syndrome involves the upper part of the esophagus. Barrett's esophagus is the lower part and Plummer-Vinson would be the upper part. Okay. Great. So, and that's itself a question. Beefy tongue or beefy tongue is a manifestation. Though it's seen with vitamin B12 deficiency, you're right. There can be dimorphic anemia occurring in these patients also. B12 component can be affected also. But then the single best answer for the anemia would be iron deficiency anemia. Okay. Keep the comments going, guys. Keep the comments going. We have talked about chyliocytosis and then we have talked about cholionicia and we move to the subsequent question here. Very good. Squamous. No, Schatzki's would be involving. Amir, you have a very good point. Though I'll discuss that in surgery, but since you raised that, Schatzki's ring, no, it's a lower part of the esophagus. Schatzki's ring is not in the upper part. No, it's the lower part of the esophagus where you could have a web present. But that was a very good point that you raised. Moving to the next question, a patient had a retroperitoneal mass and there are nests of cells in Zell-Bollen pattern. In the paper in the app, I did not put this image because I would have put this image of nests and you would not even have read the question. You would have straight away answered it as pheochromocytoma. So in the actual question, I deliberately removed the image and I wanted you to solve it on just plain theory where there is mention of retroperitoneal mass. So no mention of palpitations, hypertension, headache, diaphoresis. Normally, like all pheochromocytoma questions in our paper begin with palpitations, headache and diaphoresis in a patient. PST features are usually given. But as examiner would do, the PST features were not given in this question. It was just a retroperitoneal manifestation. And the nest of cells in Zell-Bollen pattern sustaincular cells mean that the condition that we're talking about is pheochromocytoma. It is a tumor of the adrenal medulla that causes excess catecholamine production, and because of the catecholamine metabolism, we'll go in for 24-hour urinary metanephrine levels. Option A is for carcinoid tumor. HIAA would stand for hydroxyindole acetic acid. Serum gastrin levels would be useful for diagnosis of Zollinger-Ellison syndrome. Chromogranin A is related to pheochromocytoma as well as related to even some forms of lung cancer, but then urinary metanephrine is like the best investigation for biochemical confirmation of diagnosis of pheochromocytoma. Quick comment in the chat box. In normal person, what is the major circulating catecholamine in your and my body? Is it epinephrine or is it norepinephrine? In a normal person like you and me, the major circulating catecholamine is, and I want you to set the comment buttons on fire. Normal person, not talking about pheochromocytoma. Normal person, major circulating catecholamine. Very good. In a normal person, the major circulating catecholamine would be answered as epinephrine. But if it is pheochromocytoma, then it is going to be norepinephrine. So do remember that fact that if it is major circulating catecholamine, then it is epinephrine. If he says pheochromocytoma, then your answer is norepinephrine. And if he says pheochromocytoma with multiple endocrine neoplasia type 2, that is Sippel syndrome, then your answer will change again. If he just says pheochromocytoma, what is it producing mainly? Answer is norepinephrine. But suppose I change the question to pheochromocytoma with MEN2 syndrome, multiple endocrine neoplasia, then your answer will again change to epinephrine. I hope it is clear to everybody that to two questions the answer is epinephrine for normal people like you and me. and with Mentu syndrome, that is with Sippel syndrome, we'll be having epinephrine. But if it is just plain question saying pheochromocytoma, then answer would be given as norepinephrine. Multiple endocrine neoplasia will also be associated with parathyroid adenoma. I mean, obviously there are multiple associations that are present, and they can even be, obviously there is a pheochromocytoma that is present here, but then these minor aberrations that are of the questions are one that I think should be remembered. Okay, moving to the next question. We are having a tissue of excised mitral valve. Like this patient was having either mitral stenosis or mitral regurgitation, and valve replacement was done. So now pathologist is having excised mitral valve tissue, like the original heart valve of the patient has been removed, and there is fibrinoid necrosis with mononuclear cells, histiocytes and Anishko cells. The key word in the question is Anishko cells. The moment you read that, you know that the pathology in this case is rheumatic fever. And he says what is the cause of development of this rheumatic fever, which is an example of type 2 hypersensitivity reaction. And I don't need to say anything much more than that. The moment I say the word rheumatic fever, it means autoimmunity, and the alternative term for autoimmunity is molecular mimicry between the M protein on the bacteria and the beta myosin heavy chains in the cardiac tissue, which can contribute to rheumatic myocarditis, contributing to heart failure in the patient also. If you look at the remaining options, there is no infection of the heart. It is infection in the throat, which is caused by group A beta hemolytics, that is Streptococcus pyogenes. It's not cons. So the answer is obviously not B or C, because there is no infection of the heart per se. It is infection of the throat that is occurring. Here it is written infection of myocardium or pericardium. If there is infection of pericardium, I will call it pericarditis. You know, if there's an infection of the pericardium, then I will be calling it pericarditis. Here we are having Eschkoff nodules. Here we are having Anishko cells, which are going to be like caterpillar cells which are present. And the reason why that is happening is that the antibodies that are formed against the bacteria, they start attacking self. And when antibodies attack self, then we call it type 2 hypersensitivity reaction. Rheumatic fever is another example, like mismatched blood transfusion that is asked is for type 2 hypersensitivity, where there is a molecular mimicry. The correct answer in this case is A, and you are right, Amir, in saying that there would be sterile vegetations which are present here. There is sterile vegetations which are present here. बच्चे अगर मायोकार्डाइटिस की इन्वॉल्वमेंट हो जाएगी तो फिर तो यार मायोकार्डियम एंडोकार्डियम इन्वॉल्व होगा, तो दैट विल बिकम इन्फेक्टिव एंडोकार्डाइटिस ना, देन इट विल बिकम इन्फेक्टिव एंडोकार्डाइटिस. And fibrinoid necrosis of coronary vessels, well, that would occur in Kawasaki disease, no? Kawasaki, there is the vasculitis of the coronary arteries. So option number D would be related to Kawasaki disease, where coronary vessels get affected. The correct answer in this case is option number A. Moving to 37, what is correct about malakoplakia? So normally we read about leukoplakia and erythroplakia in the oral cavity. If a person is having a white patch in the oral cavity, he is always going to be chewing gutka and pan masala, leukoplakia. If there's going to be red patch present, that's going to be erythroplakia. But malakoplakia occurs in the urinary bladder. We read leukoplakia, which is option A. We read erythroplakia, that is option number C. But where do we read malakoplakia? Malakoplakia is related to Michaelis-Guttman bodies. This is a finding that can be seen on cystoscopy in a patient who's being worked up for chronic cystitis with foamy macrophages, and inside these macrophages bacteria will be trapped. That trapped bacteria inside the macrophages are what are called as Michaelis-Guttman bodies. I'll write the name here. The correct answer for this question is option number B. The bottom line to be remembered is you have leukoplakia, erythroplakia and malakoplakia. The moment you read the word malakoplakia, what should click your mind is urinary bladder. And what is happening in the bladder is repeated UTIs causing a chronic cystitis. So you would have macrophages, and these macrophages would be loaded with the bad guys, that is bacteria. So we read about Michaelis-Guttman bodies that are found in malakoplakia. This question is more fact-based as compared to the previous one, where we had to go for a bit of an application. I would say the previous one was application-based. This is going to be like theory-based facts that have to be taken into consideration. Gamma antibodies are seen in portal hypertension. Just like we have heart failure cells in left ventricle failure, gamma antibodies are seen in portal hypertension. At the moment I say the word portal hypertension, you know that the correct answer in this case would be yes, guys. Yes. It is not autosplenectomy, na bache. Autosplenectomy is a feature of sickle cell anemia. there the spleen would be gone. It is splenomegaly. Gamma antibodies would be seen in, that's what they would have told, no? Chronic venous congestion of the spleen. CVC of the spleen is responsible for gamma antibodies. That is portal hypertension. In medicine we call it portal hypertension. In pathology they call it chronic venous congestion of the spleen. So the correct answer in this case is option number A, that is cirrhosis. B here would constitute as a silly mistake. B here would constitute as a silly mistake. If it is autosplenectomy, then it is going to be sickle cell anemia. Okay, question to you guys who have sat for the last time's paper. What is the site for accessory spleen? I think it was an applied question. No? Surgeon should look for applied spleen where in a person of ITP where splenectomy is being done. What is the site for accessory spleen, guys? It can be multiple sites. Single best answer. In a patient of chronic ITP, he said, like, he made a clinical question. Chronic ITP patient, though I'll discuss that in surgery, but still because it came, so I'm just discussing. Chronic ITP patient is planned for splenectomy. Elective splenectomy. We do elective splenectomy only 2 times, no? Hereditary spherocytosis and chronic ITP. So he said patient is scheduled for chronic splenectomy, for elective splenectomy, like where should the surgeon look for the spleen apart from the original position of the spleen, right? So it would be hilum of the spleen and the omentum. It is the hilum and the omentum where this would be present. So anyway, accessory spleen we'll discuss later, but I just wanted to be aware of the kind of depth of questions that they're asking for here. Let's recap 2 learning points in this question. Point number 1, gamma antibodies are seen where? They're found in chronic venous congestion of the spleen. That is going to be portal hypertension. That is 1. And what is the cause of portal hypertension? It is cirrhosis of the liver, which is why the answer to this question is option number A. Autosplenectomy is what you get with sickle cell anemia. It should be splenomegaly. Portal hypertension does not cause a autosplenectomy. Portal hypertension is congestion. No. So the congestion will result in development of splenomegaly in a patient. So that's the first point that I made. Gamma antibodies, CVC spleen, portal hypertension. Second I said is, like, where would the surgeon look for the accessory spleen? So that would be the hilum of the spleen and omentum where the accessory spleens can be present. So the surgeon needs to scan, otherwise elective splenectomy might fail. I hope I've been able to explain this to you and emphasize on you. Then elective splenectomy is done in 2 hemat conditions. One is where we have ankyrin defect present. That ankyrin defect is an autosomal dominant condition, hereditary spherocytosis. Second elective splenectomy is done for not acute, but for chronic ITP that is not responding to steroids. Not all patients who are having chronic ITP will be subjected to splenectomy, because splenectomy is not a small decision. It is going to be chronic ITP that is non-responsive to steroids. Immunomodulators have been used aggressively, and in spite of that, if there is going to be, like, a persistent low platelet count causing epistaxis, bleeds in a patient, worrisome bleeds, then it is like we have to be like going and pursuing the course of elective splenectomy. And before splenectomy is done, patient has to be subjected to vaccinations, because spleen protects us from capsulated organisms, pneumococcus and meningococcus and Haemophilus influenzae. So at least 2 weeks before surgery, at least 2 to 4 weeks before surgery, pre-operatively, all of these patients should be given at least 3 bacterial vaccines. Which one bacterial vaccines? Haemophilus influenzae, the Hib vaccine. And they should be given Prevnar, that is the pneumococcal vaccine. And they should also be given is meningococcal vaccine. So all patients who are scheduled for splenectomy should receive at least 3 bacterial vaccines. They also have to take 1 viral vaccine. Can you tell me the viral vaccine that should be taken, please? Quick comments, please. Yes, Sarthak, you are perfectly right. Yes, guys. Which viral vaccine should be taken in this patient? Influenza, H3N1. That's the nasal vaccine, no? That is influenza A vaccine should be taken. Otherwise, they can develop a viral pneumonia. So the vaccines that should be taken in this patient would be Haemophilus influenzae, pneumococcus, meningococcus, and then H3N1, that is the influenza A virus. So this was, like, guys, question on application. And all the miscellaneous facts that I have currently shown before you are the ones which have to be anyway, which are the ones which have to be remembered. Okay, PCV is a good answer there. Okay, rosettes. So all of you have been abroad. You all would have visited those beautiful churches where you will have these glass patterns present. This is the rosette that we're talking about, right? That light straining in through the different glasses in the various churches that you might have been to. And the same rosette pattern is what we're going to talk about, including a pseudo rosette. So first I want to zoom into this image, and in this image you can notice that there is pink neuropil that is present. Pink neuropils which are present. In contrast, in the second image that I'm going to zoom in now, you will notice that there is some projections. So you can see some projections which are occurring. These are again pink in color that is occurring, but like the whole lumen is not occluded. There are a lot of projections that are happening here at the moment, but like the whole lumen is not getting affected. No, this is not a pseudo rosette, man. This is still a rosette. Pseudo rosette is where there is a blood vessel that is present. Pseudo rosette is where there is a blood vessel that is present. If you compare the two, both of these are rosettes. The first one is having that pinkish material, the neuropil, completely occluding the entire lumen. That is Homer-right. And the second one is Flexner-Wintersteiner. Flexner-Wintersteiner will be having projections, but there might be some empty spaces present. So the bottom line is, if there is a blood vessel that is present, then the blood vessel which is present is what will be having the term pseudo rosette would come in, and this would help you understand this better if you look at this diagrammatic representation. You can see the tumor cells. I'll zoom into the diagram a little more, and you can see the whole pink material causing occlusion. Like I said initially, Homer-right rosettes, that would be like neuroblastoma. Then you can see these projections, no? These are pink projections. But there is some space present here. So this is going to be Flexner-Wintersteiner. But if there is a blood vessel in the between, then it is going to be a perivascular pseudorosette, like in ependymoma. This is, guys, like a must-know fact for you as far as the slides are concerned, because they've given these histopathology images. I think this was last year that they put up a question in the winter session of the paper, where like you had to differentiate between Homer-right versus Flexner-Wintersteiner. So if you see that pink material, Homer-right, if you see that projections, but some part of the lumen is visible, the Flexner-Wintersteiner. If there's a blood vessel that is present, that is a perivascular pseudo-rosette. Ependymoma would be the specific answers. Neuroblastoma, retinoblastoma, and ependymoma would be the specific answers for these. So these are like important questions, guys, because rosettes and pseudo-rosettes, the differentiation part is to be remembered. The correct answer for this question is option number A. Okay. Moving to the next one, which of the following is the hallmark feature of a malignancy? Metaplasia basically means change of epithelium. That can be from squamous to columnar, it can be from columnar to squamous. So either of the two can be occurring. Like columnar to squamous is in the lungs due to cigarette smoking. That was one of the questions that we discussed. And if it's gonna be squamous to columnar, then it will be Barrett's esophagus. That would be related to gastroesophageal reflux disease. That is a change of epithelium that would be happening. Dysplasia would imply, the technical meaning of the word dysplasia would mean that there would be loss of architectural orientation. I mean, the cells are oriented in a particular fashion. Here the orientation, or I can write a more technical word that pathologists love to say, loss of polarity, because all the cells are arranged in a particular fashion in the epithelium. But the highlight of a cancer is that the cancer cell will be always having a nucleus bigger than a normal cell, enhanced nuclear cytoplasmic ratio, and the nucleus is also more blue. That is called as anaplasia. Anaplasia basically would mean that there will be two things happening. One, the nuclear cytoplasmic ratio will be much more enhanced as compared to normal. The nucleus of a cancer cell, matlab, how does a pathologist know that it is a cancer cell? The nucleus of a cancer cell is bigger. And second would be that basophilia component, that it will be more blue as compared to normal. So that's one of the most important, because anaplasia means lack of differentiation. I think that's what most of the guys are coming to say, that there would be lack of differentiation is the main feature that is seen. And desmoplasia is easy. That would be a fibrostromal reaction that would be occurring. So desmoplasia can be, I mean, the easier one to be ruled out here. The most important marker for malignancy, hallmark feature of malignancy, is anaplasia. Anaplasia means loss of differentiation, but from the pathologist perspective, that's a very vague term, loss of differentiation. What you mean specifically is the nucleus of the cell is bigger as compared to normal, and it is more basophilic. So that's why the pathologists use this word intense basophilia. Intense basophilia. The correct answer for this question is option number C. Yeah, dysplasia, the basement membrane is intact, so it will be carcinoma in situ. It is carcinoma in situ. Can somebody comment, metaplasia is reversible or non-reversible? Metaplasia, reversible or non-reversible? Like if I remove smoking or if I remove GRD in a patient, then what will happen to metaplasia? Will it like go back to normal? Yes, it is reversible. Great. Ujjwal, you were the first one to comment there. It will be reversible. It is a reversible change of epithelium that is occurring in metaplasia. So standard definitions: change of epithelium, metaplasia; loss of polarity, that would be dysplasia; and anaplasia would be loss of differentiation. Desmoplasia would mean fibrous reaction. Okay, most common lung tumor, that is benign. Quick answers, please. Yes, Hassan, you are right. A good comment there. Most common benign lung tumor. Careful reading, guys. Careful reading. You guys are getting fatigued. I know you've been with me for 2 hours, and imagine in the exam it's 2.5 hours. Exam sessions are crushing. 5 hours of concentration, man. We are at 2.5 hours. It's a benign lung tumor that is being asked. Benign lung tumor is pulmonary hamartoma. Most of you are not reading carefully. You're taking it casually, man. Most common lung cancer bache is adenocarcinoma. I agree to that, but the question is saying benign lung tumor. The answer is pulmonary hamartoma. You know, if I would have said popcorn calcification, then everybody would have said pulmonary hamartoma. So do you always need a bribe of popcorn? Do you think that the examiner will always give you the bribe of the word popcorn calcification? That हम popcorn खा के ही answer बोलेंगे pulmonary hamartoma? No, na. So the correct answer in this question, yes, the correct answer in this particular question would be answered as option number D, and I'll show you an X-ray of the same as well. You can see this lesion in the lung which is like looking like a popcorn. So that would be a pulmonary hamartoma. Pulmonary hamartoma. The answer to the question is option number D. The image on the right is for again a PYQ that I'm discussing, that is cannonball mets. This cannonball metastasis that I'm explaining to you at the moment, you can quickly comment in the chat box causes of cannonball metastasis. Quick answers please, and keep talking, keep hitting the comment button. Choriocarcinoma related to molar pregnancy. Yes guys. Yes, renal cell carcinoma. Great. Good answers coming in. More. I want more. Renal cell carcinoma. Yes. Yes, all other options are the malignant ones, and the question is on benign one, no? Breast cancer. Yes, it can be ovarian also, but like the top 3 cancers that cause that cannonball metastasis would be choriocarcinoma, renal cell carcinoma, and then carcinoma breast are like those stark ones and common ones that would be present here. So 2 simple X-rays that I've currently mentioned before you should be known, and adenocarcinoma presents with pleural effusion that we'll discuss in the medicine segment. But like at the moment my objective was to mainly focus on No, it's not aspergillosis, Shubham. That was a question that had all except. Cannonball mets are present in all except. Then the answer was aspergilloma. Because aspergilloma will cause a fungal ball in a cavity. There's a cavity, and inside that there's a fungal ball that is growing. So aspergilloma grows in a TB cavity. It was a all except question that came. Cannonball mets are seen in all except. That's why I said fill it up. What are the more important causes? And these are the top 3 causes that I mentioned. Yeah, it can be seen with prostate. The studies would be lesser because prostate has more tendency to go via veins to the. In fact, that was a question that came this time, so I'll just mention it here, that how does prostate cancer mainly spread? So it is not via arteries, it will mainly spread via the veins. It will go via the Bateson plexus to paravertebral plexus to the spine, and therefore it will cause a pathological fracture of the spine. So there was a question in this time's paper. He said old man came with backache. And when doctor did a MRI, it was lytic lesions that were present, and person has been diagnosed with the prostate cancer. So how did the cancer reach the lumbosacral spine? That is why the paravertebral Bateson plexus, which would be responsible for such a profile. So because prostate cancer is not reaching like the arteries, so it's gonna be like, you know, less likely to disseminate to the lungs per se, because you need extensive dissemination for it cancer cells to reach up to the lungs of the patient. Okay, so what is the most common malignant lung tumor? Quick answers please. Overall, what is most common malignant lung tumor? Benign one is what we have discussed today, that is pulmonary hamartoma having a popcorn calcification. Yes, the most common one is adenocarcinoma of the lung. So malignant lung cancer is adenocarcinoma, not squamous cell. It is adenocarcinoma that usually presents with like a, most of the time adenocarcinoma's presentation will be with a hemithorax. It would be a massive unilateral pleural effusion that would be coming. Yeah, malignant lung tumor primary is what I'm talking. No, we're not talking about mets at the moment. No, mets can come from anywhere. That's understandable. But it is like the primary malignant lung tumor that we're talking about is adenocarcinoma and not mets. That mets is specific answer for brain now. That brain overall most tumor is mets. But for lung it is adenocarcinoma. Yeah, ALK and KRAS. Great, Nikhil. Coming to 42, this is a question of last time's paper. A patient comes with cough and weight loss for last 3 months. The biopsy shows expression of chromogranin and synaptophysin. So whenever we read about like a patient of lung cancer or suspected lung cancer, chromogranin, synaptophysin always help you in identifying that the patient is having oat cell cancer, that is small cell cancer. It's the most aggressive lung cancer. And if oat cell cancer and small cell cancer is coming in the picture, then there are two important paraneoplastic manifestations that are asked. One of the paraneoplastic manifestation will be contributing to excess production of ACTH, that is ectopic ACTH production will cause Cushing syndrome. This is the second most common one. The most common one that we see in this condition is gonna be SIADS, that is syndrome of inappropriate ADS secretion. Yeah, oat cell cancer is related to this mutation, that is LMYC, that will contribute to developmental lung cancer. But the paraneoplastic manifestation is what was asked here. The commonest paraneoplastic manifestation is SIADS, syndrome of inappropriate ADH secretion. Bache, it is not the most common symptom, but it is the commonest paraneoplastic manifestation. The commonest symptom is going to be cough and weight loss and cachexia. No? It's cough and weight loss and cachexia that would come in as a symptom. It's the paraneoplastic manifestation, SIADS, that will cause dilutional hyponatremia. So in the symptoms, it will be written cough, weight loss, early satiety, and then he will say confusion, disorientation and seizures. The moment you read about lung cancer patient is having confusion and seizures, you have to think in terms of SIADH, because SIADH will cause more water to come in the body and that will contribute to development of dilutional hyponatremia. So if he would have mentioned regarding the electrolyte imbalance in the question, it would have become easier for you. Like in medicine questions, they'll mention the electrolyte imbalance, and in pathology question, they will mention like, you know, expression of chromogranin and synaptophysin. The correct answer in this case is option number D. And yeah, I mean, Lambert-Eaton can be seen, but that would not constitute an endocrine manifestation that is occurring. Which lung cancer will cause hypercalcemia? Quick answers, please. Which lung cancer will contribute to hypercalcemia? The lung cancer is causing release of PTH-RP, that is PTH related peptide. If I talk about PTH-RP, that is pyrethormone related peptide, then like what is the cancer that we're talking about? Yes, it would be squamous cell cancer. Hypercalcemia is seen with squamous cell cancer, whereas when it comes to lung cancer, it is mainly related to oat cell cancer, is related to SIADH and Cushing syndrome, and yeah, Lambert-Eaton syndrome, which is a prejunctional defect. We have a 60-year-old lady. She came with cachexia and gross abdominal distension, and then there is a fluid thrill, there's a shifting dullness, and there's a malignant cells which are present here. The question is talking about malignant ascites in a patient, because he's mentioning fluid thrill, because there's shifting dullness. The question is asking regarding malignant ascites. For this patient of malignant ascites, yes, I'm getting A as an answer at the moment. Yes, more people please. Okay. Pseudomyxoma peritonei will be having mucin present in the peritoneal cavity. There is no mention of that. It is malignant ascites that is occurring. Guys, what is the most common cause of malignant ascites? It is ovarian tumor. You know, this lady, this is the uterus, this is the fallopian tube, this is the ovary, and there is a tumor developing in the ovary, and the cells of the tumor will disseminate to the peritoneal cavity and they will irritate the peritoneal cavity, causing ascites. And what is the commonest ovarian tumor? The commonest ovarian tumor is serous cyst adenocarcinoma. So why will a lady of serous cyst adenocarcinoma come to you is because she will be having fluid accumulation in a peritoneal cavity. This is the leading cause for development of malignant ascites, that is serous cyst adenocarcinoma. That's the clinical presentation of serous cyst adenocarcinoma is cancer cells will go and irritate the peritoneum. And irritation of the peritoneum will result in development of malignant ascites in a patient. There are two things that I hope I have been able to explain to you at the moment. One is a question on malignant pleural effusion and the second is the question on malignant ascites. If he says what is the number one cause of malignant pleural effusion, then your answer is adenocarcinoma of the lung, because adenocarcinoma develops in the periphery. Why do they teach that in pathology, that adenocarcinoma is peripheral? Why are they making you remember it? Not that they want you to cram that data, because peripheral tumor would mean it will irritate the pleura. You see, they teach you, central lung cancer, peripheral lung cancer. So adenocarcinoma causes irritation of the pleura, and the irritation of the pleura will then result in development of fluid production, and that fluid would then result in development of malignant pleural effusion. So two questions have been discussed here. Why do you get is a malignant pleural effusion, and why do you get is a malignant ascites? The answers are the commonest lung cancer and the commonest ovarian cancer is responsible for malignant pleural effusion and malignant ascites. Migratory thrombophlebitis can be seen with oat cell cancer. That's a miscellaneous fact that you have just thrown in, so I'll just mention it here. For migratory thrombophlebitis, please comment in the chat box what should I write, the word Trousseau sign or Trousseau syndrome. For migratory thrombophlebitis seen with lung cancer, should I write the word Trousseau sign or should I write the word Trousseau syndrome? Yes. It is Trousseau syndrome that is to be used for migratory thrombophlebitis. It can be seen with lung cancer. It can be seen even with GI cancers. I mean, this is not a very specific clinical diagnostic feature, Trousseau sign. The migratory thrombophlebitis can be seen with GI malignancy. And it can be seen with lung malignancy also. It can be seen with lung cancer also. So not very, very specific, I would say. The correct answer to our question is option number B. The commonest ovarian tumor begins as a malignant ascites. That's why the patient will have a tummy distension. This man came with obstructive jaundice. There is a palpable gallbladder felt in the right upper quadrant. This is called as Courvoisier law. Courvoisier law would mean that there would be a palpable gallbladder in a patient. The MRCP is showing a mass in the head of the pancreas. So we are talking about a pancreatic tumor in this case. We are talking about a carcinoma pancreas. Carcinoma pancreas will present with cachexia. Carcinoma, Steve Jobs had pancreatic cancer, no? So there would be cachexia. It will press on the common bile duct. Therefore, there would be obstructive jaundice occurring in a patient and there would be palpable gallbladder. That palpable gallbladder is what is called as Courvoisier law. So we don't get a palpable gallbladder in gallstones, but we get a palpable gallbladder in malignancies related to the GI like pancreatic cancer. Now what is the gene responsible for this? I can rule out two options for you guys. STK11 is for Peutz-Jeghers syndrome and APC gene is for familial adenomatous polyposis. Genetics is one thing that has to be learned over a period of time. You have to practice the various genes related to various cancers. Step 1 would be you have to write from top to bottom commonest cancers, parotid gland tumor, thyroid gland tumor, lung cancer, heart tumors, all of them in top to bottom, and then you need to add up the genes and chromosomes for that. Yes. The correct answer for this is option number B. DPC means deleted in pancreatic cancer. English लगाओ ना. DPC का मतलब क्या होता है? Gene which is deleted in pancreatic cancer. Option number D is related to melanoma, malignant melanoma. DPC stands for deleted in pancreatic cancer, naam ka, they have kept the name of the gene like that also itself, so that it can become easier for anybody to remember. DPC basically means deleted in pancreatic cancer. Pancreatic cancer is one of the highly aggressive malignancies. One of the most aggressive GI malignancies is gallbladder cancer and pancreatic cancer. Gallbladder cancer, if it occurs in somebody, guys, patient will die within the next 6 months. Majority of them. Gallbladder cancer is one of the most aggressive GI malignancies. If diagnosis is made today, most of the time it would have spread by the time diagnosis is made. Patient will die in 6 months. Then is pancreatic cancer. The gene which is involved in pancreatic cancer is DPC. That is, yeah, pancreatic cancer is associated with the Peutz-Jeghers syndrome also. That's a good observation. But Peutz-Jeghers syndrome, I'll write in red. Then the question should have been regarding a malabsorption syndrome in a patient. The question should have mentioned that this particular person, 60 years of age, has been diagnosed with hamartomatous polyps in the jejunum. So suppose in this question, the language of the question was that patient is having malabsorption syndrome, or is having diarrhea, and is having abdominal pain. He has been admitted multiple times in the hospital, and then we did an endoscopy and it found that there is hamartomatous polyps in the jejunum by endoscopic ultrasound. Then or by capsule endoscopy. Then I would have said yes, Peutz-Jeghers syndrome. Right? So the point here is your thought process is right. That Peutz-Jeghers syndrome is associated with pancreatic cancer. That is what came up with the chat in the app. That's our, in pancreatic cancer you are told for Peutz-Jeghers also, and ma'am has also told for Peutz-Jeghers syndrome also. So why not the answer here? Because the clinical manifestations are not matching. So that is why the answer in this case is DPC. That is option number B is to be remembered in this case. Great job, guys. Answer is sorted, and I think you are clear regarding the issues for the approach for the question also. Then this question always comes in the paper, right? Very good, Muhammad Shariak. Very good answer there. A 30-year-old patient presents with shortness of breath. Construction worker, they'll always say, and you'll always be wondering whether he's talking about silicosis or whether he's talking about asbestosis, and he has given the clean manifestation that there is bloody pleural effusion. Bloody pleural effusion is seen exclusively with asbestosis, and asbestosis will be having these holly leaf. No, this would look like a leaf. This would look like a big leaf here, so that holly leaf appearance can be present. Initially, these holly leaves will join with each other. These holly leaves will join with each other to subsequently result in development of ground glass opacities. Two findings in asbestosis that we always find is, in fact, three findings that we find is, one is holly leaf with ground glass opacities. Second we get is a pleural calcification. We don't read the calcification of pleura in any other disorder. And then we read always about bloody pleural effusion. So the hints which are given in the question for asbestosis, the hints which are given in the question of asbestosis is either a holly leaf appearance, ground glass opacities, pleural calcification, or bloody pleural effusion. That would help you identify that this question is not on the topic of silicosis. Silicosis will have lymph nodes that are enlarged, that is eggshell calcification. In fact, in my opinion, both questions were asked in last time's paper. A couple of my students said, sir, we could pick up those like lymph nodes in the chest, those lymph nodes which are calcified. That is the eggshell calcification that I'm talking about. And along with that eggshell calcification, the X-ray is also showing a couple of ground glass opacities. So if I'm reading in terms of these eggshell calcification coming up, as you can see at the moment, then I'll think in terms of silicosis. But if he gives me, the cancer is mesothelioma, Saurabh. I'll come to that mesothelioma part in a while for asbestosis. But if it is going to be this ground glass opacities or the leaf appearance, then I'll answer it as asbestosis. Now question to everybody, hit the comment button. What is the commonest cancer of the lung that is seen in patients of asbestosis? Answers are standard ones: adenocarcinoma, squamous cell, small cell, and mesothelioma. I would expect answers from you guys. Commonest lung cancer in a patient with asbestosis. Yes. Very good. The most common cancer that we see with respect to asbestosis patient is same as that of normal population, that is adenocarcinoma, only if the question says what is the most specific cancer. Only if the language of the question is what is the most specific cancer that is seen with asbestosis. For the most specific cancer, like I am saying the word asbestosis here, so cool. Asbestosis is fine. But if it says what is the most specific cancer that would be encountered, in those circumstances for specific cancer, the answer would be given by you as mesothelioma. Yes. Most of you got it right, but some people maybe missed up on that. So it is my job to just do a course correction in this case. Remember, pleural plaque calcification, bloody pleural effusion, those are features that are seen with asbestosis. Moving to the next one, hormone responsive liver tumor. For the liver also, like overall coming to the liver would be METs. Overall coming to the liver would be METs. And these METs could be coming from two areas, either from the breast or they could be coming from the rectum, colorectal cancer. Lots of time the METs that could be coming to the liver, they can come from breast or via the portal vein, they can be coming, that is colorectal cancer. So METs can be present, that is one. Another possibility in a patient can be malignant tumor, that is hepatocellular carcinoma. Hepatocellular carcinoma is the most common malignant tumor of the lung. If he says which virus is responsible for it, then I know that there would be slight controversy between B and C. Most books mention B being more common a cause as compared to hepatitis C. On a global basis, B is more common as compared to C. So cancer cases would be mainly hepatocellular carcinoma with hepatitis B. If I change this to a benign tumor, then my answer would be given as hemangioma. But now coming to the fourth MCQ and the answer to this question, hormone responsive liver tumor would mean that when OCPs are being given, OCP is causing development of that lesion, but when the OCP will stop, the tumor will disappear. The correct answer for this would be given as hepatic adenoma. The answer is option number B. There are 4 questions that have been discussed here. The overall common cancer of the liver would be METs, that would be breast cancer or colorectal. If it's going to be malignant, it's hepatocellular carcinoma. If it is benign, it's a hemangioma. But if it says hormone responsive with respect to OCP, then we'll answer it as a hepatic adenoma. So I think we are sorted for 46. Let's move to the next one. What is correct about Klatskin tumor? While you guys are going to answer it, I'm going to just make a rough sketch here. This is going to be the left and the right hepatic duct joining to form the common hepatic. This would be joined by the cystic duct to form the common bile duct subsequently. So this is common bile duct, this is going to be common hepatic, left and the right hepatic ducts present here. And it says what is specific about Klatskin tumor. So Klatskin is actually a cholangiocarcinoma. If you just know the word cholangiocarcinoma, you can solve this question here. Cholangiocarcinoma will be present at the common hepatic duct bifurcation. This is the tumor which is developing here at the bifurcation here. The correct answer for this is option number A. Great job. I think most guys got this one easy. Klatskin is always a cholangiocarcinoma. Now comes your favorite. A young girl presents with chronic diarrhea and abdominal pain, and she has mucocutaneous pigmentation of the lips. And there are polyps in the jejunum. On an endoscopic ultrasound or subsequently, like maybe capsule endoscopy was done and the polyps in the jejunum have been demonstrated. So he says like which of the following is correct about this condition? Yes guys, obviously this is not a case of celiac sprue. So gluten elimination will not work in this condition. APC gene on chromosome 5 is related to familial adenomatous polyposis, so even that can be ruled out. I have ruled out 2 options before you right away. We are left between, let's hit the comments. Okay, so everybody is fighting between B versus D. Let's resolve the tug of war. This c-KIT and CD117 mutation, this is related to development of GIST na, that kajal wala cell na, gastrointestinal stromal tumor, GIST, that originates from interstitial cell of kajal, is the one which will be related to c-KIT CD19 CD117 mutation. So you might have to sometimes approach questions on the basis of exclusion that STK11 mutation that I'm talking about is related to chromosome number 19. The correct answer to this question is option number B. I think a lot of guys were able to solve this question on exclusion. If you were, it is okay. Otherwise, this question is a typical example of what happens in the exam, where they may not give you direct options. Like everybody is habituated to getting those questions of STK11 mutation as Peutz-Jeghers syndrome, and in the actual paper the things are going to be a little different. So that's why this point has been highlighted here. The correct answer is B. Great, Mohammad Sharik, Dr. Ali, and a couple of others names that I have missed at the moment, but you did a spot on answer there. For the next question, I did not put any image in the actual question in the app, but yeah, today I put an image in the discussion so that it becomes easier for you to comprehend. That napkin ring configuration would be seen because like we go to a good hotel and the plate would be having that napkin along with the ring present. So similarly a stricture can be present because of the colon, and therefore this also gives a radiological appearance. That radiological appearance that is seen is called as a apple core appearance, because the tumor is going to be growing exponentially, so therefore the contrast will be having less space to pass across, and that's why we get that apple core appearance. This is a feature that is characteristically seen in colon cancer, and I think again was an easy pickup that can be present, and the radiological correlate of that would be an apple core appearance. So we are currently like sorted for the current question. The image is very characteristic. We can notice that stricture coming in, and that's the narrowing coming in because of the luminal growth of the encircling growth of the colon cancer that's developing in this case. And the staging that we use in this case is called as Duke staging. The next question is again a hot favorite, has been repeated upteenth number of times. There would be a painless testicular enlargement. Are we at 2.5 hour mark? Yeah, we breached the 2.5 hour mark. So see guys, you are having all the stamina with you. If you have persisted 2.5 hours with me, you have all the stamina. I'm just trying to tell you your capabilities, and you have persisted with me. So okay, painless testicular involvement. So what I'm trying to say is we'll not take a break. Let's just do this so that we are able to at least go through the main issues here. Painless testicular involvement in a male. So I know that commonest testicular tumor is a seminoma, and you can see the cut appearance that is present here, where you can see that lobulations that can be present here. Yeah, cut potato appearance that you can see for this, like a potato has been cut. And then even the fried egg appearance of the cells, the cytoplasm is clear and the nucleus looks like a fried egg. So the fried egg appearance of the cells, which is seen in dysgerminoma and seminoma, is coming up, and that cut potato appearance is coming up. I'm just wasting a couple of seconds so that I can let you come to the correct answer, guys. Yes, quick answers please. I'm talking about a seminoma. I made it solve straightforward for you. Yes guys. Okay, the correct answer in this case would be placental alkaline phosphatase that is increased. So the correct answer in this case would be given as option number A. Great. Let's now change the age group, and like this time we are talking about a patient who is a little more older. He's come with low backache. Anytime in the exam they give you a question on low backache, two possibilities to be considered: multiple myeloma and prostate cancer. Any question on old man with back pain, there can only be two possibilities. Okay, maybe I had a delayed relay coming up there. Okay, low backache in an old man, think in terms of two possibilities. Either it will be a question on multiple myeloma, or it will be a question on prostate cancer. In multiple myeloma, there will always be mention of CRAB, hypercalcemia, renal failure, anemia, and bony lytic lesion. So he will talk about the lab report of a person, or he'll talk about serum electrophoresis, etc. But for prostate cancer, he will talk about mainly the lytic lesion in the lumbosacral spine. That's why the Bateson plexus, and then a nodularity in the posterior lobe of the prostate. The commonest site for prostate cancer is the posterior lobe of the prostate. So it says which test will help in confirming the diagnosis of this condition. Confirmation of cancer is always done with the biopsy. Prostate specific antigen is only a screening test, and this screening test is never accurate because it can be false positive in case of UTI also. The answer is not prostate specific antigen, guys. Prostate specific antigen ki jagah pe what we tend to prefer is PSA velocity. What I mean by PSA velocity is that prostate specific antigen values are showing a persistent rise. That is a cause of concern. Single value of PSA can never be diagnostic. PSA values more than 4 means you suspect, but you don't confirm. For diagnosis of any cancer, you have to go in for a biopsy. It is a transrectal ultrasound guided biopsy that would be done in this case. The correct answer in this case is option number B. And yeah, PET scan or PET CT will be done for distant mets. TURP is a surgical procedure, so that anyway goes out of the window. I mean, we would have not thought in terms of transurethral resection of prostate. And anyway, we don't do a TURP here. We do a radical prostatectomy. I mean, for this guy, we do a radical prostatectomy. So the current answer for this question is, yeah, PSA. Yeah, Nikhil, you have a point. Like PSA single value can never be diagnostic. PSA values can be false positive in a case of cystitis, in a case of urinary tract infection. So no surgeon, no pathologist will take one report in consideration. It's always a rising trend. This month, August, September, October, it's rising. That's a cause of concern. So PSA velocity is more accurate as compared to PSA. And then transrectal ultrasound guided biopsy is the best one. Yeah, TURP is for benign prostatic hyperplasia. Sagar, you have a great point there. Pseudo Gaucher cells on bone marrow. So they become bored of asking Gaucher cells and that crumpled tissue paper appearance of the cytoplasm that has been asked so much times for Gaucher's disease, beta glucocerebrosidase, that they started asking pseudo Gaucher cells. Pseudo Gaucher cells will be having a similar kind of appearance, that is a crumpled tissue paper appearance of the cytoplasm, but this would be a feature that is seen with chronic myeloid leukemia, CML. Two features that must always be remembered is, one is the smudge cell, that is always for chronic lymphocytic leukemia. And for chronic myeloid leukemia, it would be pseudo Gaucher cells. And another problem in chronic myeloid leukemia is the neutrophils are like poor quality. They don't die at their expiry date. Normally neutrophils die in 6 hours. But here neutrophils live even after 6 hours, but they lose their killing capacity. So a test that we do to check for these post-expiry date neutrophils surviving in the blood is neutrophil alkaline phosphatase score or leukocyte alkaline phosphatase score. Why the score is less in this patient is because the neutrophils are past their expiry date. They have not died, but that's okay, because in cancer cells don't die. But the neutrophils have lost their ability to fight. That is why in CML recurrent infections will occur, because a lot of time a patient's relative might ask you that my dad's TLC is so high, why is he having an infection? So the TLC is high because immature cells are coming in. Because chronic myeloid is anyway a myeloproliferative stage with a shift to the left that will always be described. But the quality of neutrophils in this condition is such that neutrophils, not that they're bad, they just don't die. They simply don't die, and they're past their expiry date. If you have a cell that is past their expiry date, then it will lose the capacity to fight, and therefore the NAP values would be lesser in a patient. So chronic myeloid leukemia in a multiple choice question from pathology perspective will be having the following features. One of the highlights that will always be given would be vitamin B12 levels in this case would be elevated guys, because normally in cancer DNA requirement is more, so B12 should be less, but here B12 is more. Cancer, normally B12 should be less now because DNA turnover is more. B12 is required for DNA formation. But here the cells express more transcobalamin receptors, so vitamin B12 will be more. That is chronic myeloid leukemia, one highlight features. Second, we'll always talk about shift to left. So that would always be like myelocyte, metamyelocyte, myeloblast, all those cells would be present in the circulation. So that would always be described in a question. Then he will always talk about a neutrophil alkaline phosphatase score or leukocyte alkaline phosphatase score to be low. And the fourth thing is, suppose you forget everything, this word that I'm saying should always solve the question for chronic myeloid leukemia in pathology for you, the word basophilium. Basophil is the scantiest cell in the bone marrow. Basophil is the scantiest cell in the bone marrow. So basophilia as a word should always tell you it is chronic myeloid leukemia. Somebody commented splenomegaly. Guys, massive splenomegaly can be seen in CLL also. Massive splenomegaly can be seen in chronic lymphocytic leukemia also. So don't think in terms of massive splenomegaly as the main clinching point for chronic myeloid leukemia. Check out those words in a question. These words, if present, should give credibility to diagnosis as chronic myeloid leukemia, and they mentioned the aspect of shift to left. They mentioned the issues of shift to left. Okay. Is my screen visible, man? Okay, re-establishing the connection. Yes. So the system became tired. Doesn't matter. The system became tired. So fine, we are not tired. We are still going all the guns, right? No, it will be visible in few seconds. The chat comes a little slow. Okay guys, so 52 is what we are sorted. Acha, we are tired. So you guys need a 5 minutes break? What do you say? Quick voting, 5 minutes break. So we resume at like it's 9:27 by my watch at the moment. Yeah, Muhammad Sharik, you're right. Low LFP score in CML and PNH. So guys, the point is we go for a break here. It's you want to continue? I think 5 minutes is okay, guys. You can use the restroom, maybe just take a snack or something, and we'll come back. So the live relay will be on. We'll keep the relay on. The resumption time, we resume at 9:35. Yes, so we are at, I think we did hit that 3-hour barrier. I mean, that is like usually the barrier which most people are not able to cross. But cervical lymphadenopathy, Sheikh Abdullah, doctor, that would be present with chronic lymphocytic leukemia. CML can have a lymphadenopathy, but not very significant. Presentation of CLL is with lymphadenopathy. So we resume at 9:35, guys. The live would be on, and like 7 minutes from now, we are gonna start again. Okay, a quick short break. बगल वाला मैकडोनल्ड्स में वहाँ से एक कॉफी लेना एक ही मिलती है वहाँ पे एक ही ब्लैक कॉफी करके ठंडा वाला नहीं गर्म वाला गर्म ये ले ले फटाफट से लिख के अरे वही जो लाए थे ना सर इसको मैन के लिए वही कॉफी करनी है तो कर ले सर ये इसी वाले पे रहने दो जैसे Okay guys, so I think we're good to go for the subsequent part of our discussion. Fine. So starting with the next question, I would like people to come in quickly. So we have this person who's having recurrent episodes of epistaxis hematuria since 1 month. So they're bleeding manifestations described. And then he's having petechiae purpura on the extremities with low hemoglobin. TLC is also on the lower side. Normal is like 4,000 to 11,000. It's only 3,000. And the platelet count is only 10,000. So he's talking about like bleeding manifestations with anemia and leukopenia occurring. So all of these go in favor of a malignancy, a hematological malignancy. And then is given that classical image that comes every time, whether it is NEET PG, whether it is FMGE exam, they always give you image of that oil rods which are present. And the moment you pick up that oil rods, you know that you are dealing with the acute promyelocytic leukemia. I mean, the clinical presentation in this case is in your face, that is M3 variety of acute myeloid leukemia or acute promyelocytic leukemia is what he loves to ask. And when these cancer cells die, then the oil rods contribute to triggering of DIC, that is disseminated intravascular coagulation. And because of this DIC component, there is like bleeding of substantial variety described in this question. So the correct answer in this case would be acute promyelocytic leukemia, that is T15:17 translocation that results in PML RARA as a transcript that is formed, and this transcript would then result in defective cell multiplication. The oil rods would be contributing to clot formation and DIC occurring in this patient. The correct answer for this one is option number A, T15:17 translocation, that would be present here. Very good. I think most guys were able to straight away pinpoint to the correct answer in this particular question. Then is regarding ATRA. We use two things. In fact, one we use we don't let these patients go into DIC nowadays. One of the thing that would help in management of these patients is ATRA, which induces a cell differentiation. Though there's a side effect also that ATRA can cause a differentiation syndrome, and the differentiation syndrome is managed with steroids. But that treatment of differentiation syndrome and how do you identify that, we'll discuss in the medicine component. And another drug that we use for management of this is arsenic trioxide, which is again very peculiar because traditionally arsenic is like a homicidal poison for us, but here like we are using it for therapeutic purpose. So the correct answer is salted. And let's move to 58, the commonest variety of non-Hodgkin's lymphoma. I've already asked you this, but just to keep the presence of mind going, do the voting once again for the commonest variety of NHL. Great. Yes. This would be diffuse large B-cell lymphoma for the non-Hodgkin's variety, and for the Hodgkin's it is the nodular sclerosis variety. Burkitt's is famous because you always read about starry sky appearance. The chromosomal translocations that you see are 814, 822, and the third one that you see is 28. Because of these chromosomal translocations, there would be a defective gene, that is CMYC. And this would contribute to inhibition of apoptosis, so the cells will not die and the cells will continue to multiply. Burkitt's lymphoma is one of the fastest growing malignancies. The tumor doubling time is 24 hours. Imagine every 24 hours the tumor load will become double. The usual presentation is that of jaw swelling in an Afro-American child. The standard presentation that they always give you is of a child with Afro-American child, and then he will describe a jaw swelling, and then he will say that a lymph node biopsy was done in this case, and then he will describe that classical starry sky appearance there. This is a non-Hodgkin's lymphoma of the B-cell variety. NHL Burkitt's lymphoma is a non-Hodgkin's lymphoma of the B-cell variety. Hodgkin's lymphoma is a pure B-cell. Hodgkin's lymphoma is a pure B-cell tumor, but this can be either B or T-cell. The T-cell variety of non-Hodgkin's lymphoma is called as mycosis fungoides, or also called as cutaneous Sézary syndrome. This patient has come with again almost a patient hitting geriatric age group. Yeah, mixed cellularity common in India. A 60-year-old patient came with weakness, back pain and repeated infections. There is a M spike on electrophoresis, so no mention of CRAB this time. Traditionally they talk about hypercalcemia, renal failure, anemia and bonyclitic lesions, but this time instead of the CRAB features it is serum electrophoresis showing a M spike, which tells me that he's talking about multiple myeloma. He says prognosis in this case would be determined on the basis of, so in the international scoring score that we use for determining the prognosis of these patients, we take into consideration two things. One is the serum albumin component and second is beta-2 microglobulin in the urine. The correct answer for this is option number D. It is albumin and beta-2 microglobulin which are the main prognostic factors. Yes, LDH is also included in the parameter, but among the two close options, albumin with LDH and albumin with beta-2 microglobulin, it is beta-2 microglobulin that is to be considered. Now, why am I putting emphasis on beta-2 microglobulin is that LDH can be increased in, LDH increase can be occurring because of hemolysis also. Like if the sample is hemolyzed, right? LDH is mainly present inside the red blood cells. So if there is hemolysis of any sample due to processing error, I'm saying that hemolysis of the sample can also cause LDH to become elevated. But beta-2 microglobulin is much more specific. LDH can occur, LDH false elevations can occur if the sample is kept in, like in India it's so hot, no? So like not all the laboratories will be having air conditioning. So if in the room the temperature is 45-48 degrees Celsius where the processing is occurring, LDH values might become falsely elevated, but beta-2 microglobulin will not be excreted by the kidney. Beta-2 microglobulin is a parameter of high tumor burden as well as poor renal clearance, because ultimately the Bence-Jones proteins will block the tubules of the patient. Albumin production is less because this is a negative acute phase reactant. We have acute phase reactants. No, we have positive acute phase reactant. We have negative acute phase reactant. In multiple myeloma, the myeloma cells will produce interleukin-6. Why albumin is a component? That is again a query that I get from doctors that, sir, why are you taking albumin into consideration? Albumin is produced by liver now. In multiple myeloma, it's the kidney that is getting affected. What I am saying is that albumin is a negative acute phase reactant because the tumor load is based on interleukin. Tumor load, higher the tumor load, more is interleukin-6. And that causes less production of albumin from the liver. So that tells you about aggressive biology. And then there's a high tumor burden in a sense that beta-2 microglobulin tells about cell multiplication, because beta-2 microglobulin is the one that will cause the damage to the tubules. It will block the tubules. That's the other terminology for what we casually say as Bence-Jones proteins. The correct answer for the current question that I mentioned before you is option number D, prognosis. Just remember my statement. The most important MCQ of multiple myeloma is read the least by people. The most important prognostic marker for multiple myeloma is albumin and beta-2 microglobulin. That should be the first line that people should read. We read about infections, we read about CRAB, we read about the diagnostic criteria for multiple myeloma, and look at what he asks. He says the prognostic factor in multiple myeloma. This is the last line in medicine as well as in pathology also. I'm very, very sure that the pathologist would have told you regarding this prognosis fact in the last, because that's the norm, but he picks up a question from there. For multiple myeloma, we need a triad for diagnosis. One is a bone marrow aspiration showing more than 10% cells, that would be plasma cells. If it is more than 20% in the blood, it's a plasma cell leukemia. I'm talking bone marrow aspiration showing a bone marrow biopsy, in fact, showing a presence of more than 10% of the total cells. Along with that, there should be screening test, that is serum electrophoresis or urine electrophoresis. So it will be written as SPEP or it will be written as UPEP, that is urinary protein electrophoresis, showing a presence of a M spike. That's the second point to be remembered. That's a screening test that we do. And the third thing that we do is myeloma defining events. The third thing that should be present is CRAB. This CRAB, you don't need all of them. You don't need all CRAB. You don't need all of them. You need any one of them to be present, but these would be called as myeloma defining events that would be present. So if all the three are present in a patient, by three I don't mean from three in the CRAB. I mean bone marrow biopsy showing more than 10% cells, serum electrophoresis, myeloma defining events, then it is multiple myeloma. When I say like this, the query of a lot of students is, sir, pathologist has told 60%, you are saying 10%. By that is when the CRAB features are not present. When the myeloma defining events of CRAB is not present in the question, that is when we take into consideration the bone marrow biopsy report of more than 60%. But if it is going to be standard, right? How much is the cutoff in the setting of a crab? Then it is more than 10% to be remembered. Yeah, you can see, doctor, now I have moved my slide. It is three things should be satisfied for diagnosis of multiple myeloma. Bone marrow biopsy, that is more than 10% cells. Serum electrophoresis, shows a M spike, that is that SPEP or UPEP thing, and then myeloma defining events, that is crab to be present. All three to be present to say it is multiple myeloma. Otherwise, if suppose only two are present, then I'll call it smoldering myeloma. Or I can go a little back, only one feature present, then I'll say monoclonal gammopathy of unknown significance. But usually they keep on very specific, like they'll ask you about multiple myeloma, and in lot of apps what they will do is deliberately to make you feel and give you that FOMO factor, they will put plasma cells in the blood more than 20%. If plasma cells in the blood, if it is written plasma cells and in the blood the plasma cells are more than 20%, then you will say plasma cell leukemia. This question that you will get in various apps etc. is just to introduce a FOMO, because they're trying to say, अरे यार routine cutoff तो मैं 10% पे था, answer 20% हो गया. भाई, this is for the blood fact. It is not for the bone marrow component which is to be remembered. So that's like important domain that I would like to say, plus prognosis of multiple myeloma, albumin and beta-2 microglobulin. And yeah, we do take into consideration LDH and cytogenetics, but I told you the rationale LDH can be elevated due to hemolysis of the sample also. A 8-month-old boy is having bilateral hemarthrosis. The moment you read this, you know that there is a clotting factor issue present here. The mother is telling about easy bruisability in the child, and the workup is showing that there is increased hepatitis. Everything else is normal, but hepatitis is increased, and the gene sequencing shows a F8 gene mutation. The moment you read F8 gene mutation, the moment you read about joint bleeding, you would be able to understand that the patient is having hemophilia A. Now what is asking you in this case is that, okay, in the case of hemophilia A, what should be given to prevent these manifestations from occurring in the patient again? Okay, I can see one option in the question as cryoprecipitate. Would you like to give cryoprecipitate regularly to the patient? And cryoprecipitate, like, it can have transmission of infections also, no? Cryoprecipitate has a high chances of transmission of infections as well. Plasma, will you give plasma daily? There's limited amount of clotting factor, no? So would you give it daily? The question is on prevention of bleeding. In all patients of hemophilia, what we are supposed to do is give regular injections on weekly basis or twice weekly basis, sometimes thrice weekly basis of factor 8 concentrate. If you give factor 8 concentrate, which is manufactured by DNA recombinant technology, you can prevent these development of bleeds. Now suppose if the parents forget to get this injection done, and child is playing on the swings, and maybe the sister of this boy, because sister is a carrier, she will not be suffering from the disease, so she will push the boy from the swing, and he fell down and had a CNS bleeding. If he says a hemophilia child is having a life-threatening bleed, and what will you give in emergency? Then if you say, I want to give cryoprecipitate, I am okay with it. So I just want to say that suppose if this question was saying that the parents did not come for a couple of weeks because it is raining and the highways washed out, like they're staying away from Delhi and the main highways washed off on this Punjab side and the Kullu Manali side, and therefore they could not come down to Delhi for factor 8 concentrate, and the child had a CNS bleed. So in an emergency situation, because they anyway will not be able to reach you, and by the time they reach you, the patient will die. So in emergency, what you can be giving in this patient is cryoprecipitate. So suppose if he says life-threatening bleeding and you say cryo, I'm okay with it. But then again, the problem with cryo is the possibility of transmission of infections like HIV, hepatitis B, etc. The bottom line is, how do you prevent the bleeds? For prevention of bleeding, it is factor 8 concentrate that should be given. I will change my question. Suppose he says this hemophilia A child is playing on the swings, and the sister of this boy fought with him over the swing. You know, there's one swing in the house, and like both the children are fighting, siblings. So she pushed the boy and he had a cut on the lip, like he fell down against the wall and there's a cut on the lip. If he says hemophilia patient is having mucosal bleeding, and he says, what will you do? Then you don't need to answer cryoprecipitate. Then what will you use? You will answer DDAVP. When I say like this query, sir, DDAVP, desmopressin, that is used for central diabetes insipidus. Guys, DDAVP activates V1 receptors on the platelets. And by activating the V1 receptors on the platelets, it will be able to control the mucosal bleeding. So in hemophilia, there can be three questions. One question is, how do you prevent? If he says prevention, your answer is factor VIII concentrate. In emergency situation, yeah, I mean, I'll be more happy with fresh frozen plasma, but cryo is like, okay, if I am in a resource limited setting, it's perfectly fine. And if he says mucosal bleeding like a cut on the lip and it's bleeding continuously, then it is DDAVP that would be used for the patient. So the answer to this question would be option number D. It's the prevention part in hemophilia that is to be remembered, and the gene involved is F8 gene mutation. That's again, I mean, genetics is like you keep on adding more information. Coming to the next one, we are having this 2-year-old child admitted with recurrent pneumonia episodes, and there is trattoria. Previously, I was talking about pneumonia, and then I was talking about abscess formation. I was talking about eosinophils being increased in Job syndrome, thymic hypoplasia, there was hypocalcemia component, co-truncal abnormalities, but this time it is GI abnormality present. The moment you are having recurrent pneumonia with trattoria, think in terms of cystic fibrosis. He says, what is correct about the pathophysiology of the disease? Quick comments now. What is the problem in cystic fibrosis? The mucus in this condition is very viscid. It is English only. Mucus is viscid. The cilia in this condition is perfectly normal. Please do not mistake it with Kaltenegger syndrome. I could see a D coming up in the chat. There is impaired ciliary function is a feature of Kaltenegger syndrome. There's a D coming up in the chat. Impaired ciliary function is a feature of Kaltenegger syndrome. Now let us read option number C. Gain of function. Is there a gain of function? Or is there a loss of function? There is a loss of function. Now, why the mucus is thick is because there is loss of function of the cystic fibrosis transmembrane receptor, right? There is a loss of function with respect to the CFTR. The protein has 680 amino acids and that CFTR gene is defective, so the protein is also defective. So you have a loss of function. The main word is viscid. And because of viscid, the mucus will be stuck inside the lungs. Like in you and me, when we cough, the bulgum or the sputum can come out, but here the mucus will be stuck in the lungs. That is why there is a pneumonia. So therefore, the correct condition in this case is dehydrated periciliary fluid. Cilia are there, but they're not able to clean the lung. Cilia are there. In Kaltenegger syndrome, cilia is not working. Cleaning mechanism is not working, so understandable. But here the cilia are working fine, but the mucus is very thick and viscid. The correct answer in this question is option number B. And A is ruled out because you have high sweat chloride levels. You don't have a low sweat chloride level. So again, the question is like intelligently framed question. You have to read the options here. Don't look just at the word CFTR. Look at what it is saying. Is it saying a gain of function? Is it saying a loss of function? It is a gain of function written. So if it is working more than normal, then we are happy. No, it is loss of function which is the troublesome factor. So the correct answer for this particular case would be given as option number B in cystic fibrosis. Yeah, salty baby syndrome is a term that we can use for it. Quickly comment in the chat box, what is the investigational choice for cystic fibrosis? You want me to give options or would you like to answer it right away? Investigational choice for cystic fibrosis. Yes. Sagar was the first one to comment there, but still like waiting for you guys to comment. Sweat chloride, transepithelial nasal potential difference, gene sequencing. Yes guys, that's what I'm trying to say. It is next generation sequencing or genetic sequencing that is the answer for cystic fibrosis. It is not sweat chloride. Sweat chloride needs to be done at least 2 times. It is not a reliable test. It's a screening test. The investigational choice for cystic fibrosis is gene sequencing. I was talking to one of my dear students. He was able to clear this exam, but he got 151. So he was discussing this question with me. And he said that, boss, when the question came, no, I marked it as sweat chloride because the question said like, what is the best test for diagnosis cystic fibrosis? And like he was thanking his stars that it did not go wrong. I mean, his question went wrong, but still he was able to clear through the exam. But I just want to bring to your attention that he says कि मैंने पढ़ा ही नहीं sweat chloride के बाद में क्या दिया हुआ. Because it was sweat chloride, I assumed that the answer is cystic fibrosis. No guys, sweat chloride needs to be done at least 2 times. Sweat chloride needs to be done at least 2 times, and only then would you be able to understand. And as far as there is no repetition of questions in the paper. It is the topics that are asked, so there's no guarantees that can be given by anybody. It is just that if you can understand the technical aspects that I'm saying, then you are on the way to glory. Otherwise, obviously, like, you know, everybody tries his best, but then if you use a guidance system, the results would be relatively improved. Okay, so the answer is B there. Yeah, karyotyping is for chromosome. Good. That's a good answer, Saurabh. We have a 50-year-old man with history of recurrent falls. Recurrent falls is whenever you read, no, it's going to be PD or it's going to be HD. I mean, that's the standard lining. The neurological assessment shows dementia with chorea, not dementia at 50 years of age, and then chorea is also given. So moment I read that, I know that he's talking about Huntington's chorea or Huntington's disease, because he's saying grandfather also had a similar illness at 60 years of age. Huntington's chorea is an autosomal dominant condition. The chromosome involved is chromosome number 4, and the gene that is involved in this condition is Huntington gene, and this Huntington gene is the troublemaker here, that it will contribute to abnormal protein accumulating in the cytoplasm of the neurons, that is called as Huntington protein. This causes neurodegeneration. In the patient. This defect in the gene is CAG, nucleotide repeats. The correct answer for this question would be CAG. Huntington's chorea, cage hunting, yeah, you can use that as a mnemonic, then it's cool. Otherwise, like, the standard data is anticipation is always seen in this condition. The disease in grandfather will occur at 60, father at 50, and grandson might be at 40 years of age. So progressive decrease in age of presentation will occur in this condition. As far as the remaining options are concerned, CGG is for Fragile X. Then is CTG. If you try to use mnemonics here, I think better than mnemonics, remember this only. Though I can go into mnemonics for each one of them, so I've already given you a couple of mnemonics there. So in the end, people are not able to remember. So keep the mnemonics to a limited number. Here, instead of going for the mnemonic, like for murmurs, I've seen people trying to, in medicine, they try to use mnemonic. By the amount of effort you will use to remember that mnemonic for a murmur, it is better to understand the pathophysiology. Similarly, here, get the numbers right. It is CGG for Fragile X. Option number C was option number C of our question. CTG for myotonic dystrophy, where we get a kid with diabetes. And then GAA, where we get a Friedreich ataxia, where we get cardiomyopathy in a patient. The correct answer in this particular case is option number A, and the remaining options is what I mentioned: CGG for Fragile X, CTG for myotonic dystrophy, and GAA trinucleotides. That would be for the last entry, that is Friedreich ataxia. Good options, Nikhil. Good job. And you guys are doing a great job by remembering these details, including the genes, etc., which are to be asked for this condition. Okay, so you have a tall person. There'll always a question on a tall person coming to the OPD, and then there's a long thin face with large ears and large testes. And after that, I will stop speaking because the diagnosis is in your face. The guy is having an intellectual disability as well. Yes. What you have to pick up in this question is that this is not a question of Marfan syndrome. Marfan syndrome will always talk about features like arm span, like you will ask the person to stand like this and his arm span will be more than the height. In you and me, the height is more than the arm. In Marfan syndrome, the question will always talk about superiotemporal dislocation of the eye lens, that is ectopia lentis, which is not given here. It will talk about arachnodactyly, that is the long fingers that are seen in this patient's, wrist sign that can be seen in this patient, Steinberg sign that can be seen in this patient. Then can be cardiovascular association like mitral valve prolapse and aortic root dilatation, which can cause a aortic regurgitation. None of those features are given in this question, so this is not Marfan syndrome. The most important thing in this question is that though he started with a tall person, but then tall is also a feature that is seen with Fragile X syndrome. Yes, the most important thing in this particular question would be large testes, macroorchidism present in this condition. Hyperextensible joints can be seen. The query of yours would be, sir, hyperextensible joints can be seen in patients of Marfan syndrome. Agreed, but they can be seen even with the guy with macro testes and large ears as well. And intellectual disability that is coming up in this question as well. We don't have an intellectual disability with respect to Marfan syndrome. The correct answer to this question is option number D, that is X chromosome defect is what we're talking here. Quick answers please, diagnosis please. Yes, guys, the answer is not Marfan syndrome. I agree, the question has been a bit twisted as compared to the Marfan syndrome question that came. I think some people mentioned, yeah, that is like that PCR technique or gene sequencing is for like if we want to go for genetic diagnosis, no? But at the moment, yes, very good Naz, very good Urvashi. So you've narrowed down to the correct diagnosis. We're talking about defect related to the X chromosome at the moment, right? So I can do a karyotyping for this particular guy. There's definitely never an issue. Okay, moving to the next one. Which of the following is the smallest human chromosome? Whenever you check the karyotype, both Dr. Debeki, both can be having that. So differentiation is with respect to lens dislocation and the biochemical testing that we'll be doing. No, NEET PG, read the NEET PG notes, man. NEET PG notes are for NEET PG, no? You need to get into more in-depth data for that. Yes, guys. Waiting for answers here. I think this is an easy one. Fine. So we spoke about fragile X in the previous question, and now we are on the question that talks about the smallest chromosome, that is 21. In some books earlier, like when I was a student, they used to mention 22, but like currently they say that the shortest chromosome is chromosome number 21. The correct answer in this case should be strategy, man, is simple. Analyze these questions, do retrospective study. If you suppose in this question, that paper that we discussed, there's 60 odd. It's not 60 questions, it is 60 into 4 topics that I'm discussing before you, because we're discussing like subtopics related to each one of them. So like it's almost like I can say, if not 240, I can say like close to 100 plus topics that I've discussed today. So go retrospective, analyze what went wrong, attempt these questions again, and just check out all those subtopics that might have been missed. And as we discussed earlier, like all of you can add 10 plus marks by simply reading the questions carefully. Yes, Dr. Hassan, you're perfectly right. Moving to the next one, X-linked dominant disorder. Yeah, both examinations require a lot of depth, no doubt. Yes, not a X-linked dominant disorder. This is familial hypophosphatemic vitamin D resistant rickets, Alport, Charcot-Marie-Tooth disease, and Fabry's. Fabry's is always X-linked recessive. It is always seen in boys. So the correct answer in this case is option number D. It's a fact-based question. And whenever you read genetics, I think the starting point should be try and remember regarding XLR and XLD. Then remember autosomal recessive and autosomal dominant. Like here you can use a mnemonic RDX. AI RDX. AI is for artificial intelligence and RDX is anyway you know. So Alport, Incontinenta pigmenti, Ret, vitamin D resistant rickets, Fabry's, and Fragile X is where you can be reading regarding Fabry's disease. And for XLD, it's like Blade as a mnemonic. I have deliberately not started with hemophilia A because hemophilia A and B are like easily remembered by us. So try to remember those which are X-linked dominant and X-linked recessive. I think this is reverse. So I'll just correct it here. The data to be remembered is, I'll just like the AI mnemonic and the AI RDX mnemonic is to be remembered for the X-linked dominant disorders that I have currently mentioned before you. And then would be X-linked recessive. Blade as a mnemonic. Try to remember one of them for today. At least the I think the AI RDX for X-linked dominant ones are the ones which should be given a top priority, and then try and remember the remaining ones that I mentioned, that is Blade. And obviously like the mnemonic thing is one way to make it little easier for us, but in the end the load tends to pile up, so recall memories are of primary importance. Okay. Yeah, XLD. That is XLD, doctor. That's the swap that I mentioned. Amir, you have a point. You are analyzing a pedigree chart and came across this annotation which is present. You can notice that it's given dotted. Normally like it's a straight line. No? Normally it's always like a straight line, and in this case it's like a description for a dotted point which has been mentioned. Okay, so one is adoption into the family and second is adoption out of the family. So in this particular case, what we'll say is that the patient is having, obviously adoption part is there, but should we be saying like adoption out of the family or into the family? So the dotted mention is like this is not their original child, it is an adopted child, that is one, and the brackets are also present. So the correct thing in this case would be given as adoption into the family. And suppose if I give you a similar kind of a description and in the description you notice that there is no brackets that are given, then for the brackets without the bracket part we'll think in terms of adoption out of the family. The correct answer in this case is option number A. If I remove the brackets in this case and the dotted connotation is given, then it is adoption out of the family. I repeat my points once again. What you are seeing in this case is the kid has been adopted into the family, so the brackets come in and the dotted description comes in. If I remove the bracket, it is adoption out. Then is pedigree analysis, and you can see that yes, which of the following is correct about a pedigree analysis? Yes, guys. Yes, Hollandric gene is what we're talking about because it is male to male only transmission. Now only the men are getting affected in this case. So if only the males are getting affected, then it would be a Y-linked inheritance that we're talking about. A Hollandric gene is what we're talking about at this particular point of time. Yeah, hairy ears that can be present. Yep. Answer to this is D. In the previous session of the paper, I think it was last time's paper that they changed it. And what we could see was that the mother has transmitted the disease to all her children. But then you can notice that in the subsequent generation, the males did not transmit it. It is the girls who transmitted it to the subsequent generation. So that would be mitochondrial inheritance. Like here you can see it is the mother who is transferring the disease to all her children. And then it is males are not transmitting, it is only the females that are transmitting. So it is mitochondrial inheritance. So two line diagrams which are like usually asked, one is mitochondrial and second is the Y chromosome inheritance that is asked. He has become bored by asking about X-linked recessive and X-linked dominant. That is pretty straightforward. I'll show you those also, but mitochondrial inheritance and Y-linked inheritance is what he is going on at this particular junction when he's asking you questions. Yes, mother to all and father to none. Then is X-linked recessive where the mother will transmit only to her son. And if they give you an image where father has transmitted to the daughters, then you will say it is X-linked dominant. I repeat my statement. If it is the mother who has transmitted to her son, no, every time the mother is transmitting the disease to the son, then it is X-linked recessive. That is pretty straightforward. But if they show you a pedigree analysis in which you notice that it is father to the daughter who is getting affected, then it is X-linked dominant. So like four takes on the pedigree analysis are what I mentioned before you. Mitochondrial, Y-linked, X-linked recessive is like super easy, that I don't need to even explain, and then is the X-linked dominant one. Okay, moving to the next one. For a diabetic patient on a follow-up visit, you intend to check the KFT of the patient and electrolytes for diabetic nephropathy evaluation because that can occur. What color vacutainer would you be using so that you can be sending the blood sample of this patient for evaluation of especially the electrolytes component, because that's important. Potassium can be spiking because of diabetic nephropathy. So what color would you be recommended? Lavender is for HbA1c, no? The lavender color is mainly for HbA1c. Yes, guys. I think this is an easy one that has to be remembered, right? Yeah. Okay. I'm getting multiple answers for this one, guys, especially for electrolytes, right? Every time we have to check about electrolytes, no? Then for electrolytes, it would be like, that's a paramount importance, right? The electrolytes component would be mainly with respect to, no, guys, it would not be a, yeah, we can use yellow or we can use a red in this case. That's okay. Okay, not a blue one. So I'm removing two from the discussion here. Lavender and blue are removed here. Now yellow versus green, guys. Quickly, let's look at what would you be doing in this case. Okay. It's a simple question, guys. Simply with respect to, like, you know, you are doing a sample evaluation and then you have to check for like the electrolytes in the patient. Yes, the correct answer in this case would be like a yellow tube that I can be using here. I think we took too much of time trying to solve that question, but it is a red or a yellow that we can be doing and moving ahead in this question. Okay, check out this tube, guys, where the markings are from 0 to 100. This tube is used for evaluation of Winthrop's tube. So Winthrop's tube is used for, there are two of them. That is, one is Winthrop's tube is like for ESR distribution, and second, another one we have is a Vestigran's pipette. Both would help in evaluation of erythrocyte sedimentation rate. And then as far as ESR is concerned, which disease do you read where ESR is 100? Though there are multiple, but still, which disease do you read where ESR can be 100? Two MCQs in pathology that always mention ESR of 100. You would have seen 70, 80 in SLE, in tuberculosis. Every time you read 100, guys, not TB. If you read ESR of 100, two diseases that always come to your mind is, one is giant cell arteritis and second is multiple myeloma. Every time you read ESR of 100, no, I'm saying for multiple myeloma, even if you don't remember that triad I was talking about, you don't remember serum protein electrophoresis, you say, sir, my mind went blank, but you read ESR of 100 given in a question. Two, I mean, it can be seen even in subacute bacterial endocarditis. But multiple myeloma and giant cell arteritis, those are like, you know, must know facts where like ESR would be substantially elevated. Okay. Moving to the next one. Oval fat bodies on urine microscopy would be seen in which of the following conditions? These are more fact-based questions, guys, so I think you can be fast in prompting in answering them. Oval fat bodies would be seen in lipiduria, and lipiduria is a feature that is, yes, the correct answer is not fat embolism. It is not fat embolism syndrome. It is minimal chain disease. A lot of time whenever we are attempting these questions, we get biased by the word fat, but then oval fat bodies are a feature that is a diagnostic feature of nephrotic syndrome. It is not a feature that is encountered in fat embolism syndrome. There's a fundamental difference, guys. When we read no fat in the urine is present, or fat droplets can be present in the urine in fat embolism syndrome, that is okay. But oval fat bodies, the word oval fat bodies is specifically used for MCD, that is minimal chain disease. So both do not mean the same. And here all I can say is that here English is not to be used. I mean, this particular question, we are not supposed to use English in this case. Oval fat bodies is like always a game for sediment or like urinary evaluation being done or urine testing be done for nephrotic syndrome patient. Fat embolism with long bone fractures is fine. We use good criteria for diagnosis that we'll be discussing in our subsequent classes. Okay, one pathology finding I can add is RBCs having spikes on their surface. These RBCs which are having spikes on the surface, like if the RBC spikes on the surface asymmetrically present, is called as acanthocytes. Acanthocytes are seen in patients of A-beta lipoproteinemia. Moving to the 67th one, we have a turbid synovial fluid with 1 lakh white blood cells. 90% neutrophils present with positive birefringent crystals are present. I mean, that's the key word that you have to identify. Turbid fluid is understandable. I thought it is septic arthritis, but then he's mentioning about these crystals and they're positively birefringent, which will make it easier for you to answer this quickly. Yeah, spur cells is a good answer. Guys, I think this is an easy one. No, there are only two that are asked. One is negatively birefringent for uric acid. If I say negative birefringence, then I will say, okay, it is monosodium urate. And when I say positive birefringence, then I'll think in terms of calcium pyrophosphate. That is a presentation of pseudogout. In pseudogout, the most common joint involved is the knee joint. So if they began by describing knee joint involvement and then mentioned regarding positive birefringence, your strike rates will increase. So what they did was they did not mention at all regarding this manifestation of joint involvement. They simply said like positive birefringence would be a feature seen with. So that would be oval fat body is all varieties of nephrotic syndrome, primary as well as secondary. So MGN, focal segmental glomerulosclerosis, minimal chain disease, all of the conditions where basement membrane is damaged and there is no proteins are being lost. So lipoprotein combination, lipids and proteins are in combination in the blood. So now that combination is distorted and therefore like the fat also tends to oval fat bodies also tend to come in the urine. Okay, so we were talking about nephrotic. Another one came in. 30-year-old guy is having massive proteinuria with edema and hypoalbuminemia. Another question on nephrotic, and the foot process fusion is given in this case on electron microscopy. The biopsy report of the patient is also shown here. The answers can be quickly commented here. Pranav, congrats, and I would suggest you to use the main ones for NEET. Okay. Yeah, foot process fusion can be seen in both minimal chain disease as well as in focal segmental glomerulosclerosis. The basic point is if it's a 30-year-old man, if it's gonna be a 30-year-old man, right, not a child. If it's a man and there's a foot process fusion, and if you look at the image, light microscopy image, you can see some focal area of like if this is the whole glomerulus, then the whole glomerulus is not involved. It is some area of the glomerulus that is involved here. So therefore we will say that the patient is having focal segmental glomerulosclerosis. Yes, the error did come. I was waiting for that, and I just want to remark that on focusing on the word foot process fusion, don't think that it is minimal chain disease, because that is seen in children, and in minimal chain disease light microscopy is normal. Why the answer is not minimal chain disease is minimal chain disease light microscopy is normal. That's why the name is like that, minimal change. And the second aspect is that this disease would be more common in children, whereas our patient is an adult. More importantly, there is this focal involvement that is present. Yeah, whether you say effacement of foot processes, whether you say like the foot process fusion, ultimately it's like blunting of the foot processes are seen, and they normally help in preventing the proteins from coming in the urine. So the final point is, because of these two reasons, the answer is not minimal chain disease and is focal segmental glomerulosclerosis. Wire loop lesions are a feature of lupus nephritis, no? Wire loop lesions are a feature that would always be seen with lupus nephritis. Okay, then a fact-based question, karyotyping G banding. We use GIMSA for this, is used to determine which of the following things. So what we are doing is G banding, and that would be to determine the U chromatin and the heterochromatin. I mean, some part of the chromosome will appear light and some part of the chromosome will be appearing dark. So it is to determine the U chromatin and the heterochromatin that the G banding in karyotyping would be done. Good. The renal cell cancer that has the worst prognosis, the most common one that we see is clear cell carcinoma, which is associated with von Hippel-Lindau gene, that is with chromosome 3 association. But here the question is not asking about good prognosis, it's talking about the worst prognosis. Worst prognosis in renal cell carcinoma is seen with Bellini duct cancer. So always whenever we read about like renal cell carcinoma, the traditional question is on clear cell carcinoma, but today we are talking about aggressive one, Bellini. And renal cell carcinoma can aggressively spread by the renal vein and can go towards the heart, it can go towards the lungs, and if it goes directly to lungs, then it can contribute to those cannonball metastases that I had shown you in one of the x-rays in the earlier part of discussion. Then is the leading primary malignant brain tumor of childhood. Remember, the question is not an adult, it is in child, and is talking about a malignant brain tumor. Yes. The malignant brain tumor in pediatric age group would be answered by medulloblastoma. The benign tumor would be answered as craniopharyngioma. And then is pilocytic astrocytoma also. Both of them are benign. The difference between the two will be with respect to the location. Like one of the questions mentioned regarding bitemporal hemianopia that will come in. So bitemporal hemianopia will be seen only with craniopharyngioma because that is supratentorial. But pilocytic astrocytoma will be infratentorial in location. So there would be cerebellar manifestations that would be given in this patient, like a ipsilateral head tilt that would be described, or there can be gait ataxia that can be described in a question. So depending on the presentation given in the question, the differentiation can be made. But for childhood, it is malignant is medulloblastoma, and benign, the answer depends upon supra versus infratentorial discussion that has been given in the question. Meningioma is a benign tumor in adults. Meningioma is a benign tumor that would be found in adults. Yeah, wet keratin appearance. Yeah, I think that wet keratin appearance word was present in NEET PG. I think that wet keratin appearance, because there's a calcification around the tumor. Inside that it is cystic, but along with that, like the wet keratin appearance was given. Okay, which tumor has the highest propensity to cause tumor lysis syndrome? I did mention about it. Tumor lysis syndrome, the cancer cells will die. So there is gonna be, obviously when you give chemotherapy, there is puking. But when you kill the cancer cells, ATP will be degenerated, so phosphate will rise. Uric acid will rise because the DNA breakdown is happening. Potassium will rise in a patient, and the calcium will become less because phosphate will chelate with calcium. The tumor which is most aggressive, most prone. This is a repeat question of your paper. The question said which cancer has the highest propensity. So Burkitt's lymphoma has the highest metabolic rate. The tumor doubling time is a huge 24 hours. I mean, if I fail to diagnose this tumor today, then by tomorrow the tumor cells will increase tremendously, and tumor lysis syndrome always results in the following electrolyte imbalances that are present. So today I'll not get into rasburicase and allopurinol and IV fluids that are to be given. We'll talk about the strategy later. The main focus was to say that Burkitt's lymphoma question is famous for either the Charlie sky and jaw swelling with a lymph node biopsy report being given, or is famous for being asked for tumor lysis syndrome. Okay, which of the following will not be seen with stomach cancer? Linitis plastica is a standard presentation. The cancer infiltrates into the entire wall. Vircho's involvement occurs because the cancer will go via the thoracic duct to the left supraclavicular lymphadenopathy, so a manifestation will be seen. And because the tumor can have bleeding and person will eat lesser also, so iron deficiency anemia. I mean, there can be two reasons for anemia. One can be that cancer can cause bleeding, and second, the cancer will cause early cancer growth in the in any patient in the pyloric and will cause a gastric outlet obstruction, so he'll eat less. So therefore iron deficiency, because duodenum is the site where iron is absorbed. We get a sister Mary Joseph nodule at the umbilicus. We get a sister Mary Joseph nodule at the umbilicus. The cancer can spread and involve the umbilicus, so we get a sister Mary Joseph nodule, but we don't have is a umbilical bruising. The correct answer for this question is option number D. Umbilical mass can be present, that is sister Mary Joseph nodule, but it's not a umbilical bruising. So a question with overlap from surgery, I can say. The commonest extranodal location of lymphoma, this I discussed in the first line only. The extranodal location of lymphoma would be, yeah, that pancreatitis bruising part is perfectly fine. Yes, Nikhil, you have a good point there. Yeah, extranodal location would be like a maltoma, that would be in the stomach. So we are at the last question for today. And let's have quick answers from you guys and we can conclude the session. This would be Birbeck granules would be seen in. These would be CD1A positivity, and this is also called as Litter-Sive disease. It is also called as Christian, it's not Christmas, it is Christian disease. Christian disease and Birbeck granules would be seen with Langen cell histiocytosis. For schwannoma, you read about Antony A and Antony B bodies. Schwannoma, we always have Antony A and Antony B bodies, but Langen cell histiocytosis is where we have histiocytes, which are like modified macrophages, which cause infiltration. And in a child, you might be having an X-ray skull showing geographical skull. So every time you get an X-ray skull in a child, and he says geographical skull, then the same condition is to be considered, which will cause permeating lesions in the skull of the patient. The correct answer is option number C. So it was great, guys, interacting with you guys, and do assess how many of these did you get correct. Out of 75, my take would be 50 plus should be correct here. Among all the questions that I've discussed, because a couple of them are like pretty straightforward ones, but any scores less than 50, then I think that you need to just go into retrospective and see how things are going on. And we'll continue like doing these sessions on a regular basis, on a weekly basis. The objective of doing these sessions on a regular basis is just to sensitize you to the importance of doing this practice. I wanted to do so much of practice that in the end, in the exam time, it does not matter to you. Your nerves should become numb, and it's like with practice only that you will be able to evaluate things relatively better. Okay, guys. So we are sorted. Thank you so much for listening in. And Doc, any questions were similar to that were asked in FMG exam, no? So do listen to the FMG part, and you will be getting a lot of insight into a lot of things that could be lacking in a person's performance. I mean, both the papers were like mind-boggling ones. So thank you, guys, for joining in, and I'll see you again next week. Take care. God bless.